Good morning, everybody. Senator Hatch and I have organized today's forum because of a national crisis, a crisis of addiction to heroin and opioid prescription painkillers. Across our country, parents today are struggling with how to help addicted sons and daughters. Husbands and wives worry about spouses caught in the grip of addiction. Rates of opioid abuse, addiction, overdose, and death are a concern in schools and hospitals, treatment centers, and neighborhoods in every state. We're here today to discuss one weapon in the fight against this epidemic, to learn about its successes and about the impediments to deploying it more widely. The weapon is buprenorphine, known as Bup. Our expert witnesses today can describe better than I Bup's medical properties, but in layman's terms, Bup blocks the craving for heroin and other opioids. It dramatically reduces the physical need for drugs, and by doing so helps addicts and their families avoid the tragic damage that addiction can do. 14 years ago, Senator Hatch and I co-authored the Drug Addiction Treatment Act of 2000, commonly known as DATA 2000. When enacted, our bill allowed doctors who receive a certification to prescribe buprenorphine in their offices. Under the 2000 bill, doctors were allowed to treat no more than 30 patients. In 2006, Senator Hatch and I held a forum similar to this one, and we successfully were able to increase that limit to 100. Today, buprenorphine is prescribed in a number of forms, including brand name and generic drugs. The most commonly prescribed form, called Suboxone, combines Bup with another substance, naloxone, that makes the medication less susceptible to abuse. When I refer today to buprenorphine or Bup, I'm including all these forms of medication. It's a shorthand that I'm using. And others may use that shorthand or not. It's up to each of our witnesses here. Since the approval of buprenorphine, we have seen the dramatic, life-saving impact that it can make for those who seek to rid themselves of addiction. We have seen, we have seen hopefulness in situations where hope had been lost. Not only is Bup proven to be an effective weapon against addiction, it can be prescribed in the private office of a trained physician rather than daily visits to a centralized clinic, often some distance away, which is tantamount to announcing one's addiction if one goes into that centralized facility. We know the need is there. According to the National Survey on Drug Use and Health, of the 2.6 million individuals 12 years or older who abused or were dependent on opioids, including heroin, roughly 1 million received medication-assisted treatment. At a time when illicit drug abuse costs our nation about $200 billion a year, according to estimates, investing in making treatment more affordable is one of the best moves that we can make. As we're about to learn from our distinguished federal agency heads and medical professionals assembled here today, thousands of physicians who have been engaged in treatment with buprenorphine report not just incremental improvements, but amazing results. Several weeks ago, I sent an email survey to physicians in my home state of Michigan. They were certified to prescribe Bup. I followed that up with 2 days of meetings with doctors in their offices across Michigan. One physician in a Detroit suburb told me that he'd begun prescribing Bup with some hesitation. But today, he calls it, in his words, an incredible drug. Another physician talked about the satisfaction of seeing patients, quote, turn the corner and the light comes on, close quote. Dr. John Kitzmiller of Lake Orrin, Michigan, whom we'll hear from later on this morning, told me that he knows that with some patients, Bup, quote, has saved their lives. Yet along with this satisfaction, there is frustration. Almost every doctor I spoke to must turn away patients seeking bupe treatment because of the patient limit. One had to turn away 2 patients the day that we met. Another said that if all of his patients suddenly disappeared, he could replace all of them within a month, and he was at the 100-patient limit. Doctors said other factors limit the drug's availability. Medicaid in Michigan and many other states and many private insurance programs limit treatment to a year or less. As one doctor put it, quote, "The insurance company would never tell me I have to be off insulin in 12 months. Doctors prescribe, excuse me, doctors describe the irony that there is no limit to how long a physician can prescribe the painkillers to which patients become addicted, while they can only prescribe a drug to help break that addiction for a limited period of time. Also, some said their patients struggle with the cost of the drug. And we'll be looking at a number of other hurdles that need to be overcome if this is going to be made more widely available to meet the obvious need that is out there. Now, many of the doctors that I met with and who wrote me suggested a deeper problem, a stigma still tragically associated with addiction and its treatment. One physician that I talked to said that most doctors, quote, "don't want these patients in the office. They're seen as weak people," close quote. A second physician said he regularly fields calls from other physicians who say, quote, "I'm sending you a heroin patient. I don't want him." This stigma discourages many physicians from seeking certification to prescribe bupe. As the chart which SAMHSA has provided us today shows, and it's the chart way over here to my right, a total of 25,388 physicians are certified to prescribe buprenorphine. This is in comparison to nearly 625,000 physicians who are eligible for certification. The numbers then show that just 5,300 primary care physicians are certified, and that's only 2.5% of all primary care doctors. And interestingly enough, only 1,200 addiction specialists, less than 1/3 of the total of addiction specialists, have been certified. This sharply limits access for patients, especially in less populated areas where there may be no doctors at all that are certified to prescribe bupe. Doctors take an oath to do no harm as they treat their patients. But harm is done when opioid addiction is ignored. Every primary care physician does not need to be an addiction specialist, but they do need to be able to recognize the signs and know what help is available to assist that patient. I cannot say it enough. Unless primary care physicians can identify the disease of addiction and know how to intervene, we're going to make slower progress than we should. And as long as we have too few doctors certified to prescribe bupe, we will be missing a major weapon in the fight against the ravages of addiction. Today we have experts on this subject before us. I'm confident that we're going to leave this forum with ideas on how to identify and remove impediments to buprenorphine use, including increased physician certification. There are signs that as a nation that we're getting smarter about our approach to this epidemic. One sign is the growing use by emergency response personnel of naloxone, a drug that counteracts the effects of overdose and has saved many lives. But emergency response, while vitally important, is not enough. We need to attack addiction before the point of life-threatening overdoses. I want to thank our witnesses for coming today and for their efforts to combat this epidemic. Today we're going to hear from Michael Botticelli, Acting Director of the White House Office of National Drug Control Policy, Dr. Nora Volkow, Director of the National Institute on Drug Abuse, where buprenorphine was researched and developed for the treatment of opioid addiction. Dr. Wesley Clark, who's been here before on a number of occasions. He's director of the Center for Substance Abuse Treatment at the Substance Abuse and Mental Health Services Administration. Dr. Eleanor McCants-Katz, Chief Medical Officer at SAMHSA. Dr. Andrew Kolodny, Medical Director of the Phoenix House Foundation, President of Physicians for Responsible Opioid Prescribing. Dr. John Kitzmiller of Lake Orion, Michigan, who is certified to prescribe Bup at the 100-patient limit. And Ms. Colleen LaBelle, Program Director, State Technical Assistance Treatment Expansion Office-based opioid treatment, and to expand that treatment with buprenorphine. She is accompanied by 2 patients who are now in recovery. A number of our witnesses are also accompanied by others, and they can introduce them at that time. We hope our witnesses can give us a sense of what impact buprenorphine is having in the battle against addiction, what hurdles exist to its wider use, and how those hurdles can be removed. Again, I want to thank our witnesses, and I particularly want to thank Senator Hatch. His dedication to this issue has made a lasting difference to people in need. We couldn't be where we are legislatively or with getting our colleagues involved in finding ways to deal with this epidemic. We couldn't be where we are at without Senator Hatch. He's a great colleague and a great friend, and I now call upon him.
Thank you, Senator Levin. I appreciate it. And I appreciate all of you being here today as well, taking time to give us your opinions on the prescription drug abuse crisis. And I'm especially grateful for my old friend here, Senator Levin. We have a long history of working on these issues together, and Carl's leadership and expertise should be both celebrated as well as emulated. I'd also like to recognize Jackie Parker, Senator Levin's longtime staffer and a good friend of mine. Jackie has made sure Carl and I stay focused on this important issue, as have my own staffers as well. And it breaks my heart to realize how many families are suffering due to a family member or friend engaged in opioid drug abuse. On average, 23 Utahns die each month from prescription opioid-related deaths, most of which are overdoses. Deaths related to prescription drug overdoses have now surpassed the number of deaths from car crashes, both in Utah and nationwide. That's astounding to me, and it's alarming. We have to act. In 2000, I joined Senator Levin and then Senator Biden in drafting the Drug Addiction Treatment Act of 2000, which authorized licensed physicians to prescribe buprenorphine to patients abusing prescription opioids. As you all know, buprenorphine is a medication used as a substitute for prescription opioids. And when we passed that law, physicians were allowed to prescribe to no more than 30 patients at one time. The program was such a success that in 2006, Senator Levin and I joined again to introduce the Office of National Drug Control Policy Reauthorization Act, which raised the limit to enable physicians to provide these prescriptions to up to 100 patients. Now, I want to share a few stories from physicians in Utah who have been treating patients with this medication. Dr. Carl Hebden from Salt Lake City, from the American Board of Addiction Medicine, has had great success in using this drug to treat his patients and is constantly reaching the 100-patient limit. Dr. Hebden shared with us the story of one of his patients, a 44-year-old registered nurse. This nurse started, as most opioid abusers do, with an injury. In his case, a car accident. He was prescribed narcotics and with time became addicted as his tolerance to pain decreased and his tolerance to narcotics increased as well. Soon after, he lost his license, health, and of course his marriage. In his moments of despair, he reached out to Dr. Hebden, who quickly prescribed him buprenorphine. He is now, in his own words, quote, "on a path to finally getting my life back. It is great to have a life I enjoy. It is also so great to have a life at all," unquote. Now, another story comes from Dr. Sterling Potter from Price, Utah. He is the only licensed physician to prescribe buprenorphine in his area. He shared with me the story of one of his patients, a 21-year-old young college student. This young lady came from a comfortable background, a supportive family, with a promising future ahead of her. But sometime during her senior year in high school, she was introduced to heroin. Her rapid descent led to the loss of 3 different jobs, her university scholarship, and ultimately her health. She quickly became addicted, and despite multiple efforts at rehabilitation and detox, she relapsed over and over again. This young addict was unable to keep sober for more than a few days at a time, which led to an eventual near-fatal overdose. The emergency facility suggested she contact Dr. Potter, who might be able to assist her. Now, Dr. Potter put her on buprenorphine and kept close contact with her throughout the treatment. 15 months later, she is completely off heroin. She hasn't relapsed once since she started the treatment, and she has developed a strong relationship with her family members and is excelling in college. I almost said Congress, my gosh. I've heard more stories like this from doctors in Utah. Indeed, we have similar stories from doctors all over the country. Now, raising the patient limit from 30 to 100 has enabled thousands of people to receive treatment. But the demand for drug abuse treatment is still outpacing supply in my small home state of Utah. With a state average of 14.3 annual deaths for every 100,000 adults, prescription opioids take a high toll on Utahns. Drug abuse plagues thousands of people across the state, and we simply do not have the resources to help all of these people. And this is a state where people are proud of their religious beliefs and their tolerance of others, and also proud that they generally don't use drugs. The purpose of this meeting is to hear input from some of the experts in the field of drug rehabilitation to determine what further measures must be taken to address prescription opioid use and to discuss buprenorphine as a treatment for that abuse. Regarding the 100-patient limit imposed on physicians, we have asked some of these doctors to share their observations and input on the subject. Dr. Michael Crookston from Cottonwood Heights, Utah, medical director at Adult Dayspring, explains, quote, "I am always right at the limit. It can be heartbreaking to turn patients away when I know how life-changing and life-saving buprenorphine can be. Buprenorphine is the only drug with a numerical limit on the number of patients that can be treated. And it is so wrong that the physicians who have the most training and experience with this drug are unable to use that knowledge and experience to help as many people as possible. We still have a large unmet demand for buprenorphine here in Utah. I could easily help at least twice as many people if it were legal to do so," unquote. Another item I'm concerned about is that physicians, in an effort to help more people, are not able to deliver the best care to their patients. Dr. Troy Lunsford from Payson, Utah, he expounds, quote, "I have changed how I practice medicine because of the restrictions placed on buprenorphine with 100 patients. There have been times that I think patients could benefit staying on medication longer, but in order to try and help other patients, I have titrated them off so I could start another patient on buprenorphine." Now, we can't afford to jeopardize the quality of care for these patients. Likewise, it is of the utmost importance that we respond to the needs of those suffering from drug addiction. With the law the way it is, we do not have enough licensed physicians to administer buprenorphine. Doctors around Utah, especially among rural communities, are saturated and cannot meet the needs of all their patients. Many doctors have had to turn people away, and there are people in Utah that have traveled throughout the state or even across state lines to find a certified physician who has not reached his or her patient limit. I'm sure there are many of you in this room that would agree that this is truly disturbing and not what we want to see when it comes to caring for patients dealing with serious drug addiction. Let me just say this, that it's a pleasure to work with Carl Levin. We've worked on these kind of problems for a long time together. He's one of the great senators here, and I've really enjoyed working with him. He takes this matter very, very seriously, as do all of you. And it's just a privilege to work with him. I'm just sorry that he's decided to hang him up and, you know, go for filthy lucre. I don't think you're going to do that, are you?
Not a chance.
Not a chance.
Lucre maybe, but not filthy.
Lucre, yeah. But before...
Neither one.
Yeah, before he does leave, we're going to get a bill through with your help that will solve these problems. Now, to me, if these doctors have to be certified and go through that process, and it's an intense process, I think we've got to trust them to be able to help people, even though the drug itself is addictive. And we ought to let them help as many people as they possibly can. And we ought to regulate it as well as we can so that the doctors feel confident in themselves that they can handle these type of problems. So I have to go to we have a markup this morning in the Finance Committee, so I'll have to leave. But I look forward to learning about your remarks on these and other important issues. And I'm really eager to hear your recommendations. This is a very important meeting. I understand it's going to be a lengthy meeting, and you're going to really give every aspect of this a try, and hopefully come up with your best recommendations for Carl and myself, for Senator Levin and myself, so that we can do what really is necessary here and hopefully get it through both houses of Congress in a time of tremendous interconflict between the two branches and even within each branch. And he and I will see that that happens, and frankly, we're very grateful for all of you taking time and being here with us today. If you'll forgive me for leaving, I'm already probably going to be late, but and it's an important meeting because it's we're going to mark up a number of people who will be on the Social Security Commission, so it's very important that I be there. But I'm going to take a tremendous interest in what you have to say, so you can count on that. My good friend will keep me up to speed on what he and others are going to do in this particular area, and we're going to help you in every way we possibly can. So thank you all for being here and forgive me.
Thank you so much.
Forgive me for leaving.
No, and I think everyone understands that. And Senator Hatch, we know where you have to be at this hour when we schedule these events, can know exactly what conflicts there are. But in addition to our staffs, and thank you for mentioning our staffs and singling out Jackie Parker. I was going to save that for later, but our staffs are also going to help make sure that this is transcribed quickly, this hearing, and that it's brought to the attention of our colleagues and any recommendations that require legislative action so that we can, and again, it's on a bipartisan basis. We don't do enough things around here, frankly, on a bipartisan basis, and when we are able to do that, the chances of success are much greater. And Senator Hatch is one of those who crosses the aisle all the time, and we just wish that, frankly, we had more like Senator Hatch here, but thank you very much for being here.
Vice versa. My staff's going to be here, so we're not going to miss anything here, and they work very, very hard with Senator Levin's staff, and we're going to get this done. Help us to know how to do it the best way possible, and be a little bold on this because there are a lot of people that need this help and aren't able to get it, and there are doctors who I think would like to be certified who aren't. So let's go from there. Thanks.
Thank you. Thank you again, Orrin. Okay, let's start with Michael Botticelli, the Acting Director of the Office of National Drug Control Policy in the White House. If you can, limit your remarks as we go around the table to about 5 minutes. There'll be much more time for expanding those during our comments and questions that will follow all of the presentations.
Great. Senator Levin, Senator Hatch, thank you for convening today's forum, but I think most importantly for your extraordinary leadership on this issue over the years. I can't overstate the importance of Data 2000 and these drugs in terms of their ability not only to diminish the stigma related to substance use disorders, but by the countless lives that have been changed and saved through this medication. I'm very pleased to be joined today by my colleagues from ONDCP, June Civilli and Jamie Delano, who are the heads of our treatment branch, as well as federal partners and some old colleagues, long-term colleagues that I've known for a long time. Be happy to talk about the administration's efforts to address our approach to drug policy. Our national drug control strategy is based on science and evidence. It begins with recognizing that addiction is a brain disease that can be prevented, treated, and from which one can recover. As Senator Hatch mentioned, overdose deaths, primarily driven by prescription drug abuse, have now surpassed auto crashes as the #1 cause of accidental death in the United States. Along with the increase in overdose caused by prescription drugs, we have also seen an increase in heroin and heroin deaths. Both heroin and prescription drugs are included in a class of drugs called opioids. They have similar effect on the brain, which can be successfully treated with medication-assisted treatments such as buprenorphine and other FDA-approved medications. I'd like to provide a brief overview of the administration's strategy and review the important role that medication-assisted treatment plays in addressing substance use disorders in this country. The administration's inaugural strategy, released in 2010, established 5-year goals to reduce drug use and its consequences in the United States. A major component of the strategy is integrating treatment for substance use disorders into mainstream health care. This includes the expansion of treatment in community health centers and improving the quality of evidence-based substance use treatment. Integrating treatment into primary health care will increase access to treatment and close the significant treatment gap that exists for substance use disorders. According to the most recent data obtained from the National Survey on Drug Use and Health, only a small percentage, approximately 10% of people with a substance use disorder, receive treatment at a specialty facility. The increase in the abuse of opioids, including prescription pain medication and heroin, has created unprecedented demand on our nation's treatment system. Long-term maintenance treatment with FDA-approved medications for treating opioid use disorders or relapse prevention, combined with behavioral therapies, has shown to be more effective than treatment without medication. Additionally, studies have shown that medication-assisted treatment can be cost-effective, preventing criminal recidivism and blood-borne infections such as viral hepatitis and HIV, and saving lives by preventing overdoses. And there is consensus on the value of MAT. In 2007, the National Quality Forum Standards of Care to Treat Opioid Use Disorders recommended pharmacotherapy linked with psychosocial treatment and support for all adult patients diagnosed with opioid dependence and without medical contraindications. MAT should be recognized for the standard of care for opioid use disorders, and yet for far too many people it's out of reach. As been indicated in 2013, only 8% of treatment facilities were certified by the Substance Abuse and Mental Health Services Administration to provide treatment with methadone and/or buprenorphine. Treatment programs are often unable to provide this standard of care or unwilling to provide this standard of care when we know there is significant need. More than 1.1 million physicians who can write controlled substance prescriptions. As indicated, only about 25,000 of them received a waiver to prescribe office-based buprenorphine. Of those, 7,600 had completed the requirements to serve up to 100 patients. The remainder can serve up to 30. Although they were augmented by an additional 1,378 narcotic treatment programs, only a small number of physicians, that has been indicated, are electing to use medication-assisted treatment for their patients. As it has been talked about, medication-assisted treatment for opioid dependence is underused and underutilized. A recent study of 345 private sector specialty treatment programs found that among the 266 programs that had access to at least one prescribing physician, adoption of each treatment medication, methadone, buprenorphine, or naltrexone, had occurred in less than 50% of these programs. The low rate of adoption of methadone was expected since programs that exclusively offer methadone treatment were excluded. Among programs that had adopted medication-assisted treatment, actual implementation, meaning prescribing to patients, averaged only 34% across all medications combined. To expand the use of medication-assisted treatment, my office has convened a group of federal agency representatives to review federal programs, policies, and administrative authorities. This group, called the Treatment Coordination Group, has been tasked with identifying barriers to medication-assisted treatment and to explore ways to increase medication-assisted treatment for opioid use disorders. This Treatment Coordination Group seeks to coordinate individual federal agency efforts to improve access to substance use disorder treatment, increase the quality of treatment services, and make sure systems are in place to adequately monitor the outcomes of these services. A number of states, including Massachusetts, Vermont, and West Virginia, are also implementing treatment models to provide access to medication-assisted treatment, and particularly buprenorphine, in primary care settings. We need to encourage other states to adopt such models to improve patient access. Providing training and technical assistance to physicians and their teams interested in implementing these models is shown to be likely to help them become active providers of this highly effective outpatient treatment. As you will hear from my former colleague in Massachusetts, Colleen LaBelle, in Massachusetts, we implemented a nurse care manager model for medication-assisted treatment, and particularly buprenorphine. We used this model for several reasons. The Commonwealth, like the United States, was moving forward toward integrating primary care services with substance use disorder services. And although there were a large number of physicians with DEA waivers to prescribe, we had very low prescribing rates. We anticipated that as we implemented statewide healthcare reform, we would see new patients coming into the healthcare system who would need both primary care services, and we knew that we had an extraordinary opioid abuse and dependence issue in the Commonwealth like we do in the United States. Therefore, we increased the capacity of primary care settings, federally qualified health centers, and others to provide substance use disorder treatment through the use of buprenorphine. We also provided education to healthcare providers to increase their knowledge of substance use disorder treatment and to build a payment system for sustainability of substance use disorder services through reimbursement and billing. Massachusetts funded the nurse care managers and provided technical assistance and case consultation for the nurses. To study this success, we studied Medicaid clients who were prescribed buprenorphine and methadone. And ultimately, what we found that overall expenditures were lower for these clients than those who didn't get treatment. And we also found that clients on medication-assisted treatment had lower rates of relapse, hospitalization, and emergency room visits. So not only is this an effective medication, it's a cost-effective medication and actually reduces Medicaid costs. Another interesting finding was that younger and newer clients who were coming to buprenorphine who had never been in treatment before. Although we had achieved some success in Massachusetts across the country, we have not fully utilized our primary care infrastructure as an access point to substance use disorder treatment. Primary care settings, including federally qualified health centers and health centers within the Department of Defense and Veterans Affairs, offer rich opportunity for integration. Once again, I would like to thank both of you for your unwavering commitment to this issue, and I look forward to discussing these and other points more in depth this morning. Thank you.
Thank you very much, Mr. Botticelli. Dr. Volkow.
Senator Levin and Senator Hatch in absentia, I want to also thank you for your leadership on this issue, which of course has now reached what we sometimes call epidemic proportions. Now, I was specifically asked to speak about buprenorphine, and in listening to your entry comments about the notion to the extent to which we can justify the limit of 100 patients per clinician, and the other issue that is very, very relevant, the lack of acceptance of buprenorphine, despite the fact that the evidence showed that it's beneficial. And as a result of that, very minimal the number of patients that could benefit are receiving it. So what is driving this? And I think that it's a misunderstanding about how buprenorphine acts. There is a stigma associated with the use of an opioid substitution therapy under the belief that you're just changing one drug for the other. But the reality is that while buprenorphine targets the same receptors in the brain as morphine and heroin that are associated with reward, it does it in very different ways. Number one, it's much less potent. That means that even though it occupies all of the receptors, it does not have the maximal effects that you have with heroin or morphine. Advantage, you don't have the rewarding effects. And the second one is much less risky with respect to overdoses. The other issue that people don't understand is that while activation of these receptors, the mu, it's called the mu is rewarding. The speed at which you activate them is crucial to producing reward. And as a result of that, for a drug to be very rewarding, it has to get into the brain very rapidly. And that's why heroin abusers inject it, because it goes from here directly into your brain. Whereas when we give these medications, we give them orally, and that has to go through the stomach, the liver, and then gets into the brain very slowly. That, in and of itself, decreases its rewarding effects. And buprenorphine occupies those receptors very, very slowly. But once it occupies it, it binds very, very tightly. And that binding very tightly is why it's such an effective drug for the treatment of heroin, because it will interfere with heroin binding to that mu-opioid receptor without producing the same effect. The other aspect that many people don't consider is that heroin and morphine are going for this mu. buprenorphine also binds to other receptors that in animal models are actually beneficial in drug taking. So it's not just the mu, buprenorphine binds to kappa, delta, and nociceptin receptors, all of which are relevant for the treatment of substance use disorders. And finally, buprenorphine, on the way that it's most frequently used in the United States, is combined with an antagonist in such a way that if you inject it, you are going to have much less likelihood of getting a high. So these are the differences between buprenorphine and heroin and morphine that most people just don't even think about, and they just combine them together and says, no, 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 it's one drug versus the other. And that is incorrect. Second one, does it work? And you have all cited, and Mr. Botticelli has also cited clear-cut evidence that buprenorphine improves the ability of patients from abstaining from heroin, from relapsing, for sustaining on treatment. It also decreases the likelihood of getting infected with HIV because, of course, they are not injecting. But it also improves their adherence to antiretroviral treatment for those that are HIV positive. The other thing that is clear-cut, very relevant for what we're seeing in the United States, buprenorphine treatment decreases overdoses, deaths from overdoses. And the other thing, let's not forget, it also decreases incarceration and criminal behavior. So wherever one looks at it, buprenorphine improves the outcomes, and it's cost-effective. So what are we using it? We're using it just certainly for the treatment of heroin addiction. We're using it also, and the evidence is already there, that it is beneficial for the treatment of patients that may have pain but are addicted to their pain medication. There's also evidence that buprenorphine is effective in the treatment of adolescents that are addicted to opioid medications. And finally, there is also evidence that it is effective in women that are pregnant, that are heroin abusers. And one, of course, of the very adverse effects is that these newborns are born with withdrawal symptoms, and many of them end up in the intensive care unit. Treatment of buprenorphine, in fact, has been shown during these pregnant women to decrease the number of days that these infants stayed in the intensive care unit quite significantly. So all of these issues, of course, determine, well, the other aspect that we need to consider in all of this is what are its benefits versus other treatments like methadone. And I think that it's not a good strategy to combine one versus the other because both of them are very beneficial. But buprenorphine has a tremendous advantage. It's less potent, and therefore it is safer. As a result of that, we can use in an office base in the healthcare system, bringing the treatment of substance use disorders directly into the healthcare system. Its longer duration of action allow you to give the medication 3 times a week, as opposed to methadone that needs to be given on a daily basis. And those, obviously, another big advantage, the risk from overdosing are actually lower than that of other medications that we currently have. So what are the challenges? And I think that the challenges are very clearly delineated, related to policy. Why is it that we have a policy that relates to limit 100 patients? You can argue, is it because opioids are very dangerous? But we don't have those limits for physicians that are treating chronic pain, for drugs that may be even more potent. Fentanyl, you don't have a limit. So what is the logic behind that? But that's policy, and I think that in terms of the scientific evidence, what is it that we can give you to actually make the best decision? With respect to treatments, buprenorphine is very valuable, but there are also other ways to maximize its adherence. So one of the areas, for example, that we're funding at NIDA is can we develop buprenorphine medications that instead of being given daily or 3 times a week, can be given once a month. And I think that the final area of research that is very, very important is the implementation, as Mr. Botticelli has shown. There are many evidence-based interventions that have been shown to deal with much better outcomes, but are not being implemented. And the question is why. So what type of research we can do to determine what is the optimal infrastructure and strategy that will maximize the likelihood that patients will be given buprenorphine when they need them, and that will be monitored properly. Thanks very much.
Thank you so much, Dr. Volkow, and for all your work as well. And that goes for all of you who are putting a good deal of time and energy and commitment into this battle. Dr. Clark, welcome again.
Good morning, Senator. I want to thank you and, as Dr. Volkov pointed out, Senator Hatch in absentia, for convening this forum and for inviting the Substance Abuse and Mental Health Services Administration to participate. We know that many advances have been made in improving access and treatment for those seeking medication-assisted therapy since the passage of Drug Addiction Treatment Act of 2000. But there's still much that can be done to help those who misuse or abuse opiates. Prior to data 2000, opioid agonist therapy was available only in methadone maintenance programs. The only office-based treatment available was oral naltrexone, which was not often selected by opioid-dependent patients because it blocks the effects of opioids as well as alcohol, but it's also difficult to get people to come back for refills. The enactment of Data 2000 promised millions of Americans the opportunity to obtain agonist therapy through the privacy of a physician's office in addition to federally certified opioid treatment programs. The approval of Suboxone and Subutex increased the availability of effective medication-assisted treatment for opioid use disorders and gave substance to Data 2000 because Data 2000 was predicated on the availability of a Schedule III medication, which didn't occur right away, but did occur. More recently, the Food and Drug Administration has approved 2 new formulations of buprenorphine, naloxone, Subsol, and Bunavil. Bunavil is not yet available, but is coming. So these formulations will join Suboxone to provide prospective patients with more choices that may make treatment more acceptable. In addition, the availability of monthly injectable Vivitrol for relapse prevention of opioid use provides alternatives to agonist therapy, and it shows promise in attracting patients who might not otherwise benefit from opioid agonist addiction treatment. SAMHSA is responsible for overseeing the regulatory compliance of certified opioid treatment programs which use methadone and or buprenorphine for treatment of opioid addiction. Currently, there are 1,311 OTPs. In addition to OTPs, SAMHSA registers physicians who intend to prescribe or dispense buprenorphine for the management of opioid addiction, a process which is done in conjunction with and coordination with the Drug Enforcement Administration. According to the Data 2000 as amended, a physician may not treat more than 30 or 100 patients at any one time, and you've mentioned that. There are over 25,000 active data wave physicians, 7,800 of whom are authorized to prescribe up to 100 patients. And we estimate a total of over 900,000 to 1.2 million patients are served by these physicians. Because the data legislation is without regulation, it doesn't allow the Department of Health and Human Services to exempt a physician from exceeding the 100-patient caps. SAMHSA has encouraged physicians to consider applying for OTP certification under 42 CFR Part 8 rules. We've tried to work with the medical community to increase the interest in using buprenorphine. We find it, as others have pointed out, somewhat paradoxical. The physicians who use opioids can help create a problem, but there seems to be a reluctance, as both you and Senator Hatch pointed out, to help address the problem. The department is also considering the need for changing the cap for providers through regulations that are currently certified. The lack of sufficient access to buprenorphine certified physicians in some underserved areas is a continuing challenge. Data 2000 only permits physicians to prescribe medications for the treatment of opioid use disorders using agonist therapy. Therefore, a nurse practitioner or physician assistant who might be permitted under federal and state statutes to prescribe a Schedule III product for treatment of pain is not allowed to prescribe buprenorphine products for managing addiction. SAMHSA has worked with state substance abuse agencies, federally qualified health centers, and the Indian Health Service to provide training for primary care physicians in order to raise the awareness of buprenorphine treatment. Many of SAMHSA's training modules have been adapted to utilize webinars, online education, and other technologies to increase the availability to reach practitioners located in rural areas. In addition, SAMHSA funds a physician clinical support system for buprenorphine. This program was expanded recently to include other medications for the treatment of opioid use disorders. The expanded program, called PCSS, Medication-Assisted Treatment, is designed to educate current and future prescribers regarding appropriate prescribing practices for pain and other medications subject to abuse. The PCSS is actively engaged in providing continuing medication education to primary care providers, including those interested in prescribing buprenorphine. SAMHSA has also been assisting the Centers for Medicare and Medicaid Services to develop and release an informational bulletin for states regarding the use and inclusion of buprenorphine in state Medicaid plans. Through these and other ongoing efforts, SAMHSA continues to work through ensuring those who need medication-assisted treatment receive it, and those physicians who want to provide those services are able to do so. Impediments to these efforts include the inability of non-physicians, such as nurse practitioners, to prescribe buprenorphine, the managed care strategies of some private and public insurance plans that make it difficult for some patients to participate in treatment, and the current patient number limitations. And also, some states have proposed regulations that, if enacted, might make it more difficult for some patients to continue participating in treatment. My colleague, Dr. McCants-Kat, is going to address in some more detail the barriers that exist in expanding the number of beta-wave physicians. So I will defer to her on this. Thank you.
Okay, we'll get back to her then in a second. We'll go down in the order that I described, and then we'll come back to you, Dr. McCants-Katz. That's okay. Dr. Kolodny.
Senator Levin, thank you for having this meeting.
You know what? I'm wrong on that. Reverse the order. I thought I was following a script, but I followed the wrong script. So we're going to go now to Dr. McCants-Katz. So forgive me, Dr. Kolodny, for doing that. That's what happens when you are bound to a script and you read the wrong script. So.
Well, thank you, Senator Levin, and also to Senator Hatch for convening this event to discuss the status of office-based treatment of opioid use disorders and the use of buprenorphine in treatment of these disorders. I'm going to spend a few minutes describing the history of physician education efforts on office-based treatment of opioid dependence and efforts going forward. Data 2000 made it possible to greatly increase access to treatment for opioid use disorders, as well as to bring addiction treatment into the mainstream of medicine. Data 2000 required that physicians who were to offer this treatment be qualified to do so. And the law described a number of paths to qualification, mainly related to certification in addiction psychiatry or addiction medicine or participation in related clinical trials, but the most frequently utilized route to qualification was to take the 8 hours of training provided by one of the national organizations named in the law. This aspect of the law required these groups, the American Society of Addiction Medicine, the American Academy of Addiction Psychiatry, American Psychiatric Association, and the American Osteopathic Academy of Addiction Medicine, to develop an 8-hour training that would provide physicians with little to no experience in the treatment of addictive disorders enough information to give them a solid foundation in assessment for substance use and commonly occurring mental and medical disorders, confidentiality and medical record keeping requirements, clinical pharmacology of buprenorphine, and how to use the drug in the clinical setting. SAMHSA funded the development of this curriculum, which served as the foundation for all 8-hour trainings offered in the ensuing years. SAMHSA also initially funded 8-hour training programs across the country so that physicians could obtain the waiver and begin practice. In 2003, the pharmaceutical manufacturer began to fund 8-hour waiver trainings across the country with a focus on high-need areas based on the epidemiology of opioid abuse at that time. In addition, several of the national groups named in Data 2000 developed an 8-hour online course for those who wanted to obtain the waiver but were unable to attend an 8-hour classroom-style training. In 2004, in response to the growing need identified for mentoring to assist physicians who had limited experience in addiction medicine and who expressed concerns for starting a practice not familiar to them, SAMHSA established the PCSSB, the Physicians Clinical Support System for Buprenorphine, which provided national and local mentors to physicians and assisted in raising the number of physicians willing to take on this practice following waiver training. In 2009, when the manufacturer's patent on buprenorphine products expired, the classroom-style waiver trainings which they had supported also ended. At that point, SAMHSA supported the metamorphosis of the PCSSB to a program of waiver trainings as well as mentoring. SAMHSA also supported the development of a new version of the 8-hour waiver training to that of a 4-hour self-study and 4-hour face-to-face training that could be given by a single instructor. This version of waiver training addressed critiques from physician participants which cited the difficulties that practitioners have in leaving their practices for as much as 3 days if you include travel on either side of that full-day 8-hour training. And this training method was far less expensive than the traditional 8-hour training that utilized multiple trainers and was usually held in a hotel venue so that participants would have to have a place to stay while they were being trained. This course was welcomed by residency training programs because of the ease of delivery and the opportunity for physicians in training to obtain a waiver prior to leaving residency training. To date, 24,960 physicians have a waiver to offer office-based treatment of opioid dependence, and 7,826 have the waiver to treat up to 100 patients. However, we are also aware that the majority of those with waivers still do not prescribe buprenorphine naloxone to treat opioid dependence. This has led us at SAMHSA to explore the reasons why this might be the case. We've met with federal colleagues from HRSA, CDC, and ONDCP to explore these issues and have received feedback that a barrier to implementation of this practice is a lack of implementation tools. These tools would include more detailed information on induction procedures, additional training materials directed toward office staff to support their work with patients receiving buprenorphine, and more detailed information on issues related to documentation and billing. Programs of practice observation and mechanisms by which such programs could be established are being considered. SAMHSA will continue working with our federal partners and thought leaders in the field to determine the means by which we might accomplish these goals. We at SAMHSA see this as an important priority given the rising rates of opioid use disorders related to prescription pain medication abuse and an increasing problem with heroin use in the United States. The National Survey on Drug Use and Health underscores the scope of the problem with its estimate that over 2.5 million Americans met criteria for an opioid use disorder in 2012. We believe that Data 2000, office-based treatment of opioid dependence and buprenorphine treatment, as well as utilization of other FDA-approved medications for the treatment of opioid use disorders, are essential to addressing this urgent public health issue. Thank you.
Thank you very much, Dr. McCants-Katz. And now we'll go to Dr. Kolodny. Thank you, Doctor, for an article that you wrote that was brought to my attention by Jackie Parker called Naloxone Necessary but Not Nearly Enough. And also, Dr. Volkow, I read a recent paper of yours that you wrote with a number of others called Medication-Assisted Therapies, Tackling the Opioid Overdose Epidemic, and I read that as well, and that's also an extremely well-written paper, and I know others of you have done writing recently, which I have not read, so I can't thank you for it, but I failed to thank you for that paper. I thought it was very succinct and extremely effective. Now, we're at Dr. Kolodny.
Thank you, Senator Levin, for having this meeting and for the invitation to participate. 14 years ago, when President Clinton signed into law Data 2000, reports from New England and Appalachia were just beginning to surface about OxyContin overdose deaths and addiction. At the time, no one could have imagined that we were in the early years of what would become the worst drug addiction epidemic in U.S. history, an epidemic that has led to the loss of more than 125,000 lives between 1999 and 2010. When you first began working on Data 2000, opioid addiction and overdose deaths were not the high-profile topics that they are today. Back then, the picture looked very different. People suffering from opioid addiction were disproportionately African American and Latino, and they were from some of America's poorest communities. Very few lawmakers were interested in the problem. You were a notable exception. We are exceedingly fortunate that you introduced Data 2000 when you did. Had you not made it possible for the medical community to treat opioid addiction with buprenorphine, there is no doubt that the epidemic would be far worse today. Tens of thousands of lives have been saved because of your historic legislation. Today's discussion on expanding access to buprenorphine treatment is exactly the conversation we need to be having. Too often, the discussion of this issue is framed around reducing opioid abuse and misuse, which is important, but it is the wrong way to frame the issue. Opioid abuse and misuse are not diseases, they are risk factors. Medical use is another risk factor. The correct way to frame this public health crisis is as an epidemic of opioid addiction. The distinction is important because when we correctly frame the problem, the public health interventions necessary to bring it under control become clearer. We must do for this epidemic what we would do for any disease epidemic: prevent people from developing the disease and see that people already suffering from the disease are able to access effective treatment. To prevent new cases of opioid addiction, the medical community, including dentists, must prescribe more cautiously so that we don't directly addict our patients and so that we don't indirectly cause addiction by stocking medicine chests with a hazard. For the millions of Americans now suffering from this disease, we must do everything we can to rapidly expand access to buprenorphine treatment. With treatment, sustained remission and recovery from opioid addiction is possible. I began treating opioid addiction with buprenorphine in 2004. My patients have been young adults, most of whom became addicted through non-medical use of painkillers, and they have been older adults, people in their 40s, 50s, 60s, and 70s, who became addicted to opioids through medical use for chronic pain. Over time, I've had the opportunity to see my younger patients on buprenorphine get married, have babies, graduate college, and start careers. And I've seen my older patients resume their roles as parents and spouses and become involved again in their families and communities. I've also heard very sad stories from my patients about their friends who did not access treatment, friends who developed hepatitis C after transitioning to injection drug use, friends with multiple arrests, friends no longer able to care for their children, and many friends of theirs who lost their lives to accidental overdoses. In communities hit hardest by the epidemic, buprenorphine treatment capacity is not coming close to meeting demand. This is due in large part to caps on the number of patients a physician may treat, ineligibility of nurse practitioners to become waivered, inadequate integration of buprenorphine into primary care, and stigma, both of the disease and the treatment. I am hopeful that today's discussion will lead to policy changes that ease these barriers. A medicine that can treat opioid addiction should not be harder to access than the medicines that are causing this disease. Unless we are able to rapidly expand access to buprenorphine, the outlook is grim. Overdose deaths will remain at historically high levels, heroin will continue flooding into our neighborhoods, and our families and communities will continue to suffer the tragic consequences. Thank you.
Thank you very much, Dr. Kolodnian. Thank you for your comments on our 2000 legislation. Dr. John Kitzmiller, welcome to Washington. I think this may be your first visit, is it? When we met in Lake Orion, I asked you, was it your wife who had not been here before, or was it you? In high school. I'm afraid I probably was here too when you were in high school.
Am I supposed to press this button?
Yeah, we should have.
Oh, thank you.
Your red light should be on.
Well, thank you very much, Senator Levin, for having me here. I'm humbled to be here. And while I am a practicing physician who does prescribe and use buprenorphine, I think the purpose of me being here is to tell maybe a more personal story of things that I brought up to you in the office when you came to see me. I was a vascular surgeon for 30 years in Michigan. Starting in 1985, I began a series of 10 back surgeries on myself over about a 20-year time period. And during that time, obviously, I took opiates and abused opiates and became addicted to opiates. And in 2007, which was around my 8th back surgery, I think, I was still practicing vascular surgery. My son was in Iraq fighting, and my father had just died, and I was living at home. And it was about 2 weeks after my surgery, and I didn't really care about anything at that point. I would wake up and take some more opiates and go back to bed and kind of hope I didn't wake up. And my office manager called me one day and she said, "Would you be willing to go into treatment?" And I said, yes, I would. So I went to Brighton Hospital in Michigan, and I was there for 4 months. And they were using Suboxone then, and I was discharged from the hospital on Suboxone and was doing very well. My spine surgeon said I could no longer do surgery. I just couldn't stand at the operating table anymore. So it was time to move on and find something else to do. I was too young to retire. And I went back to school and got a master's in psychology at, I think I was 60 or 59. And that's actually where I met my wife. She was one of my teachers. And
My wife teaches me all the time.
yeah, yeah, it keeps going. And I was still on Suboxone during my master's program. And I thought, you know, I'm doing well. I don't really need to take this, and I'm fine. And I stopped. And I think it was within 3 or 4 months that I was back on opiate medication. The urge, the craving to take the medication is so incredible, and that's one of the major, really the major issues. I mean, Suboxone or buprenorphine helps get through withdrawal, but probably more importantly, it takes away cravings for opiates. And that seems to be an ongoing problem for opiate addicts. And so I started back on Suboxone, and I take it now. And I've been taking it. But I had essentially lost everything. I mean, I lost, you know, I couldn't work anymore, lost my home. And it has allowed me to come back and have a very active medical practice, taking care of people with chronic pain and opiate addiction, and has returned me to, I think, a functioning member of society. Obviously, I have a lot of patient stories like everybody else does, but one comes to mind. I'm seeing a couple, husband and wife, who are both heroin addicts, and they're on Suboxone now. But interestingly enough, I'm seeing their son. They've been on Suboxone now 7 months and are doing very well. But I'm seeing their son as, from a psychology point of view, he's 17 and in high school. And he told me the other day that every day walking home from high school, he was afraid he was going to come home to his parents being dead on the floor. And now his parents are doing very, very well. They're both working, and he's, doing much better too. But it's a drug that allows us to lead a normal life. We can't lead a normal life on opiates, can't lead a normal life on methadone, but you can take Suboxone and lead an absolutely normal lifestyle. And I think I wanted to share that with people.
Thank you for sharing it. It's a powerful story, and you're a powerful person for what you've been able to do and are doing to help others as well as yourself. Ms. LaBelle.
Good morning. Thank you, Senator Hatch and others, for inviting me here today. It's an honor to be here to represent Massachusetts and the work we've done there. In 2002, following the enactment of Data 2000, which was authored by Senator Carl Levin and Senator Orrin Hatch, Massachusetts hit the ground running. In an effort to provide treatment for addiction using buprenorphine in an office-based practice, with the FDA approval in 2002, buprenorphine quickly made its way to the pharmacy shelves by 2003. Our phones were ringing off the hook, people were searching the internet, people were learning about this life-saving treatment, and they wanted it now. And these were people different than the population of an inner-city hospital that we were typically used to treating. At that time, we went to our state authority, the Bureau of Substance Abuse Services, which was headed by Mr. Michael Botticelli, and we asked him if he would sponsor a nurse care manager model for our data-waived physicians in our inner-city hospital as a pilot to facilitate treatment. It would provide us with the level of support and resources needed to minimize the barriers of treatment of this complex disease in a primary care setting. The demand quickly outpaced our ability to treat more patients, and within a month, we had a growing waiting list of patients desperate for treatment. We, at that time, were restricted by the law of 30 patients per federal tax ID number, and we got creative, learning we actually had 3 federal tax ID numbers in our institution, more than that of Kaiser Permanente. So with that, we treated patients again, but however, that too was a Band-Aid, and our waiting list grew to over 300 desperate people seeking treatment for a medication that was in fact giving patients their lives back, rebuilding families, and the difference between life and death. With further legislative changes, we were then able to treat 30 patients per provider, and by 2006, physicians were able to obtain the extended waiver to treat up to 100 patients at a given time. The demand did not stop there. Access was challenging, with less than 2% of the physicians in Massachusetts at any given time that were waived to prescribe buprenorphine. Again, BSAS, the Bureau of Substance Abuse Services, stepped up and put out a request for proposal to state community health centers, targeting federally qualified community health centers, to implement models mirrored after the Boston Medical Center model, with waivered physicians paired with nurse care managers to treat patients with buprenorphine. Physicians at the sites had to be willing to obtain a waiver to prescribe buprenorphine, and health centers had to identify dedicated nurses to be trained and committed to the program that would be monitored and overseen with a statewide technical support. BSAS released an additional RFR to provide the training and technical support to the funded community health centers, and this was awarded to us at Boston Medical Center. I have been the program director for this statewide expansion of buprenorphine in the federally funded community health center since its startup in 2007. When the grant began, the Bureau funded every applicant that submitted a proposal, and again put the RFR out 2 more times to try to access sites that had a bigger need and to get more community health centers on board. The funding for each submitted, the proposal continued to support the additional health centers, community settings, anyone out there willing and able to do buprenorphine treatment in their sites, providing technical support. This initiative allowed widespread dissemination of treatment in community settings, engaging providers, and thus far has treated greater than 8,000 patients since its inception. The nurse care manager model allows physicians the support of trained nurses that can provide the assessment, the intake, the education, the induction along with the physician, stabilization, and weekly and less and more frequent monitoring based on the patient needs. The complexity of treating patients with addiction can be very daunting, and physicians don't typically have the time to treat large volumes of patients in their busy primary care practices. Putting this model into place has allowed physicians that technical support and services of a trained nurse so that they can further treat patients. We then looked at the Medicaid data, such as Michael spoke about, of treating patients and looking to see what substance uses and costs were for patients that were in care. And looking at the data we've collected from the 14 funded health centers, we found that patients stayed in care for 6 months and up to 12 months, the cost went down. Emergency room visits decreased, inpatient stays decreased, and expenditures, of course, declined as well. Recently, I was asked by a patient who was also a social worker, an advocate, a peer leader, and a member of a board of the Bureau of the Community Advisory Committee at the Bureau of Substance Abuse Services. He said to me, "Colleen, how many patients have died in your program while on buprenorphine?" It stopped me in my tracks as I thought through the 11 years of buprenorphine treatment that we've done at Boston Medical Center, where we have treated 450 patients or more at any given time. I reviewed the data. I found deaths from liver cancer, lung cancer, liver failure, and cardiac events, but not one death from a patient in our program from active addiction while in treatment. People die when they're not in care. Every day in Massachusetts, we lose 2 or more people from overdose. People don't typically die when they are getting treatment for their addiction. Treatment works, and this is evidenced by the 2 guests that I brought here with me today, Sherry and Ellis, who are here to share their stories on addiction and the wrath of destruction it's played in their lives. However, they're here today because treatment works and buprenorphine has given them a new lease on life. Ellis has re-engaged and united with his daughter and spends his time supporting the struggles of others struggling with addiction as a mentor and a sponsor. Sherry's a mom to her daughter and has enrolled in college in the hopes of attaining her degree and a better life for her daughter. We all continue to struggle with this public health epidemic and the demand for treatment. Listening to the stories of patients buying and self-maintaining with buprenorphine from the street for 1 and 2 years because they couldn't get it in a program that took their insurance. I was at a parent group on Monday night, and they too admitted to buying Suboxone on the street for their children. Accessing services has remained challenging. 11 years later, Massachusetts has 5% of its physicians waived to prescribe buprenorphine, and half of them serving limited numbers of patients or not accepting insurance at all. However, the funding to community health centers, prior to the initiation of the grant, there were 21 physicians that were waived in the 14 health centers that were funded. 7 years later, those health centers have 162 waived physicians that have been trained. Patients continue to wait for treatment, calling providers listed on resource lists, hoping to get lucky and find someone willing to treat them. Why do we treat addiction so differently? Why is access to care so challenging? How many diseases do you have to call a laundry list of providers to find someone with an open slot that takes your insurance, that's in close proximity to where you live or work? Do you have to call every day or once a week to keep your name active or at risk of being lost from the waiting list? We're making patients jump through hoops for a chronic disease that people die from, waiting for care, that are challenging to those of us who are not even struggling with addiction. Buprenorphine's impacted the lives of thousands and changed the way we treat and care for patients with addiction. However, in the midst of this public health crisis that's killing people every day, we need to do more. We need more treatment, we need more evidence-based care, and it needs to be accessible. There's nothing more heart-wrenching than picking up the phone to call the next person on the waiting list. And on the other end of the phone, there's silence with a big sigh, and then you're told that person's died from an overdose. No one should have to wait for treatment. There needs to be readily available on demand where and it's needed and when the patient wants it. Thank you.
Thank you very much for that great statement and for all your work, Ms. LaBelle. Do you want to introduce your 2 associates here?
Sure, so there's Sherry and Ellis. I don't know who wants to go first.
Well, that's an old-fashioned guy.
He is an old-fashioned.
Yeah. Sherry?
Thank you for having me here today. It was
You could
really
talk right into the mic, it'd be great.
closer.
Yeah, you can pull
How's
the whole
that?
thing closer if you want.
How's that?
Good.
Better? Okay.
Thank you.
So I'm really glad to be able to be here today, and thank you for taking the time to listen to me. I am one addict. I've been in recovery for nearly 5 years now. I was a heroin addict. I'm going to give you a little bit of my history, what brought me to addiction, and how recovery has changed my life. So addiction runs in my family very strongly. Both my parents, my sister, Other relatives are all either addicts or alcoholics. It's something I grew up around, and it was a traumatic childhood for me, but it was familiar, and I grew up around it. And I was out on my own by the time I was 16, and I very naturally was drawn to drugs. What heroin did was it numbed all that pain that I felt from having lost, family and never really having any support or guidance growing up. So I didn't have much of a life to lose. I was an addict, and I worked. I bartended and waitressed, and it went on like that for a number of years. I tried to get clean. I didn't want to be doing what I was doing, and I would try day after day. I would throw out my works, and I would want to stop. And that pull is just so strong. And by the middle of the afternoon, I couldn't hold out. And I went through several detoxes. But coming out was the problem because I didn't have a way to maintain. I didn't have support around me. All I knew was what I knew. And the physical draw is just intensely strong. I used to describe it as just trying to stop eating. And eventually you just have to. And that's what it was like for me. So eventually I found treatment, and I started on Suboxone. Actually, I was pregnant at the time, and I was only a few weeks pregnant, and it was the time when I finally really wanted to get clean. I really wanted to, give everything. I just couldn't go on how I was. I wanted a life, and I really had nothing. So I was about 4 or 5 weeks pregnant, and I was lucky to find out when I did, and I went on Subutex then. And I stayed clean throughout my pregnancy, and I started to find a support network and people I could talk to about, what was going on, because I was always very closed in and really unable to, feel what I was feeling. I just needed to block everything. My daughter was born, and I was starting to, feel stable and good, and I had a plan, and her father was with me as well. He did not go into treatment. He stopped on his own, and he ended up relapsing. So then it was just myself. When my daughter was born, she was born with a rare genetic syndrome called Williams syndrome. It's a spontaneous microdeletion of approximately 25 genes. So this kind of changed everything for me. I had this plan. I was doing well, and I knew where I was headed. I said, okay, I can do this. I can get it together. And suddenly I have this child, this baby, who has incredibly complex needs. I was at the hospital with her, 3 to 4 times a week for the entire first year. She had a couple of hospitalizations. It was very challenging. And suddenly I couldn't work. I had to go into a shelter because I couldn't support us. And neither could her father at the time or my family. And thank God I was on treatment then, because that was one of the most difficult things I've had to go through. And I really don't know that I could have done it without, because I had the times when it would be strong, that very strong urge, just numbness. I don't want to feel this, because I hadn't learned how to feel yet. Drugs block that ability. And with the Suboxone, it's like an extra step. With the blocker, you have to consciously stop taking it if you're going to use drugs. And that little extra step saved my life. So today, I've been in treatment over 4 years. I have a good life. I have a stable life. I have a life for my daughter. I've been able to break that cycle that's run in my family and be a parent to this child. She needs so much. And I've been able to be there for her, and I've been through parenting classes, and her father is clean again, and we are together. And I'm in school. I've actually done really well in school. I'm surprisingly smart.
Doesn't surprise anyone listening to you, I'll tell you that.
I really didn't know that about myself. I didn't know my capabilities, you know. And today I do. Today I don't set these limits for myself. Like I have a future, and my child has a future, and I've been able to help other addicts around me. And I'm very grateful for the treatment that I've gotten, and it does work. And that's it. Thank you.
Well, thank you for sharing your story with us. And it's extraordinarily clear and strong. Thank you.
Thank you.
Mr. Kaur?
My name is Ellis Kaur. I want to thank you all for inviting me. It's an honor to be here today, to meet the senators and everything. Usually I see you guys on television, but being here is unreal.
We're even better looking in person, aren't we?
Yeah. I was born in Selma, Alabama, back in the 50s. My mother decided to leave Selma, Alabama, a lot going on down there, and come to Boston. So we came to Boston. And she always instilled in me the right morals, the behaviors, and spiritual understanding of the church. They were strongly church people. 6 kids in the family. She separated from my father, who stayed in Selma, Alabama. So I went to school. To make a long story short, I was a good all-around basketball player. I was voted most likely to succeed when I graduated. This was around 16, 18 from military school. I don't know how the drugs came in the picture. She did not warn me about drugs. We never knew anything about drugs in the neighborhood. But eventually I got involved with it. And for the last 40 years, I've been battling on and off with drugs. I've been in every treatment you can imagine, from halfway houses, therapies, methadone, the whole works. I fell into crime because I never committed a crime unless I was on drugs. I commit many crimes, burglary, drug-related crimes. I've been in and out of prison constantly. I've been in every Massachusetts prison and jail in the state of Massachusetts in the span of 40 years. I was also, one time, New England Most Wanted as far as burglary. I mean, the drugs were so strong. I could not break it. I tried everything. I really wanted to change. I really wanted to. I had a daughter and family. I burnt a lot of bridges. I destroyed a lot of my family that believed in me. Up to 9 years ago, I relapsed again. I tried harder. I had a job. I built up everything, was about to get married, and a relapse. everything's gone again. I got sick and tired of it. I gave up hope. I lost faith. I thought I was born to, be this way. I ended up at the hospital. I don't know how I got there, but I remember Colleen standing over me. I have a picture of it, and I was, really in shambles, skinny. And she brought a cup, told me to throw up in it, get the drugs out of your system. And for me to go home and take these pills every 2 or 3 hours and call me. From that day, I had been clean for 4 or 5 years. I don't know how it worked, but it worked. I left with destructions of wreckage behind. I began to mend relationships with my daughter. I started to pay off my taxes. I started to get rid of my criminal record. I got rid of my criminal record. Today, today it feels like a court here. I'm so used to courts, and you're the judge, That's why it's unreal. Here I am telling you my story, and I don't have to be locked up. But I think it's a miracle. I mean, you have to have a lot of tools in recovery. This drug is so insidious. It's so cunning. It's so powerful. And to have it, and for it to have me do the things I've done, I feel really bad about it, because I wouldn't have done those things if I wasn't under the influence of drugs. And once you're sober on the Suboxone, I seen the trail of destruction I left. I quickly had to make amends. I had to go to therapy. They had counseling. I had to go to AA, NA, things that go along with it. But I had confidence. It brought back the confidence that I can do this, and I'm not afraid of relapsing, because I know I have the Suboxone, and I don't want to relapse. I mean, that's the thing. Like Sherry says, you have to want to be clean. It really works. It's easy when you want to be clean. Also, when I was in prison, I don't know, maybe I caught hepatitis C or B or whatever it is. I decided I wanted to work on my physical health. And it makes you want to just give you the strength to repair all the damage you've done. And a lot of my friends and relatives see me and they say, what do you have? What are you taking now? What do you? It's like, because they knew that there was nothing on this earth that could make me sober again. But this Suboxone worked. I did a year, last year. I just finished it up in March, I believe. I had the antibiotics of hepatitis C, and now I do not have the antibiotics. And I was proud of that. So it's something I told Colleen I would never have took that treatment without the help of that Suboxone. It gave me the strength. It just motivates me a lot. I don't think it's magical, but it's different from all the rest. I believe I saved the state of Massachusetts millions of dollars. I pay back everything I owed them. I have money in the bank today. I have a relationship with my daughter who I married off just in time. I got straight just in time to marry her off. She's married to a career captain in the Navy. They live in Virginia. And she called me 3 months ago, and she was just breaking up in her marriage. because she was in a car accident. She was taking pain medicine for her back or something. And it had an effect on her marriage because she got hooked on those pills. And I told her about Suboxone. She never heard of it. I told her about Suboxone. And she's been on it, and now they're back together. And she's happy about it. And her mother says, well, Ellis, that's about time you did something right. I came into her life just in time. So I'm not going to glorify Suboxone, but I know if it can work on me, it can work on a lot of other people. And I heard the stories. I like what you said down there about it, because I like to research things and see how it works. But it works, and it makes sense to me. A lot of friends in the street are coming to me, and I point them in the direction of Suboxone. Some out there had it in the street, and they try to even buy it off me. I told them it's against the law. You cannot, but go to the pharmacy, Colleen. But there's a big demand for the guys out in the street. And they all told me, you know, tell the truth, go up there and tell them. It works. They need help. And if they wanted to, along with, you know, therapy and everything, it works. Thanks for listening to me. Thank you.
Thank you so much, Mr. Kaur. And the story of Suboxone giving you strength is, I'm sure, very true, but you got an awful lot of inner strength, which is necessary as part of the whole picture. Thank you for telling us and sharing with us your story. And now we're going to call on Dr. Corey Waller, who's with the American Society for Addiction Medicine. You're also with Spectrum Health, and we very much appreciate the good work that Spectrum does, but perhaps you could share a few minutes now of your efforts and your beliefs. We appreciate it. Thank you.
Sure. First, I'd like to thank the people who I see and treat every day, our patients, and want to make sure that we represent them through this whole process, because that's really important. And again, thank you, Senator Levin and Senator Hatch, and then Jackie Parker, whom I met a couple of years ago, and since then we've been able to pull together, I think, a really good idea of what appropriate treatment is for patients. So I'm the director of the Center for Integrative Medicine, which is and I'm the substance use medical director for our community mental health in our county, and the acting chief for the Division of Pain Medicine at Spectrum Health in Grand Rapids, Michigan. Currently, I'm here representing the American Society of Addiction Medicine as well as my patients. And ASAM was established in 1954 as a professional medical society representing over 3,000 physicians and allied health professionals, including a growing number of nurse practitioners and physician assistants. ASAM is dedicated to increasing access and improving quality of addiction treatment and educating physicians and the public, supporting research and prevention, and promoting the appropriate role of physicians in the care of patients with addictions of all types. Last fall, ASAM released the latest version of its patient placement criteria, which has been adopted as the major pathway for how we place patients into treatment and send them through. We've also recently put out the first standards of care for addiction medicine, and we'll soon have performance measures and very soon to follow guidelines for the treatment of opioid use disorder. So Data 2000 enables, as we've talked about today, qualified physicians to treat up to 100 patients. You can start with 30 and move up to 100. And unfortunately, the combination of addiction treatment shortage at large and an opioid epidemic at the 100-patient limit is seriously restricting patients' access to treatment. ASAM surveyed its members regarding their buprenorphine prescribing practices in 2013. Results illustrate the difficulties even addiction medicine specialists are having in meeting patient demand. Over 90% of respondents reported that the DEA waiver to prescribe buprenorphine to at least 30 patients with 3/4 of those prescribing buprenorphine certified to treat up to 100 patients. However, nearly half reported patient demand in excess of 100 individuals. And furthermore, according to the American Board of Addiction Medicine, by 2020, there's going to be a demand of at least 7,000 qualified addiction specialists to treat the 8 million patients with this disease. This does not take into account the additional primary care physicians who will need to be educated about proper prescribing of pain medications as well as medications to treat addiction, as well as for the brief intervention and screening of all of these patients to determine who is at risk for this disease. So the last 2 decades, we've seen a dramatic increase, and a lot of this had to do early with how we perceived pain treatment. And this dramatic increase was not flanked with a dramatic increase in access for addiction medicine professionals to see patients. And we lost that initial sprint race. And so it is really important for us as we move forward for these 8 million people to treat more than the 1.5 that we've given access to for all of these addictions. And moreover, in a recent national survey conducted by the National Association of State and Alcohol Drug Abuse Directors, 37 states reported increased admissions for heroin abuse. So 37 out of 50 have an increase. That's the vast majority of our country. Michigan and Utah have also not fared so well. We have more patients die in my state of Michigan, as you're well aware, Senator Levin, from opioid overdose than we do in car accidents, and it's the same in Utah. The rise in prescription drug abuse has also given way to an increase in heroin abuse, because as we start to lock down prescription medications in the emergency departments and in primary care facilities, and someone goes to the dealer that they've gone to obtain those, and all they have is heroin, that's what they take. So nearly half of the young people who injected heroin reported abusing prescription drugs before abusing heroin. Individuals may transition from prescription drugs to heroin because it is cheaper, and quite honestly now, it's much easier to obtain. Fortunately, there exist highly effective therapies to treat opioid addiction, including FDA-approved pharmacotherapies like buprenorphine. All of these medications, buprenorphine, methadone, and naltrexone, have been shown to both clinically and cost-effectively treat addiction, as well as all of the social ailments that go with addiction, including broken families, broken communities, and quite honestly, broken systems of care to deliver these therapies. So buprenorphine, as we all know, was first approved to be prescribed in an office-based setting as a take-home prescription, an advent opioid addiction pharmacotherapy that had great appeal to many concerned with the stigma associated with methadone treatment programs and the way that those have been set up. For many others, buprenorphine solved a logistical dilemma because not everyone was able to easily access a methadone clinic, especially in rural areas where there are none, and we have many of those in Michigan who have zero access to methadone treatment. And not everyone is able to easily access even other pharmacotherapies such as naltrexone. So timing is a crucial element in the successful treatment. Addiction treatment providers from all backgrounds often talk about readiness to change as a leading factor in treatment success. And conversely, denial of treatment leads to a continued misuse and abuse, physical and emotional decline, and ultimately death in a number of our patients. In order for a qualified physician to adequately treat this disease, he must be able to address all of the patient's needs and offer all of the treatment options at that point of care. Arbitrary treatment limitations like patient prescribing limits, as well as time limits of prescribing, have resoundingly negative effects on the treatment access, quality and outcomes, questionable positive effects on the controlling of diversion. You know, the effective experience of our members has guided the development of the following proposed solutions to this, because we all know it's a problem. I think it's important for us to work toward appropriate solutions to get good treatment. And as referenced above, one solution for tackling this epidemic is to increase the buprenorphine prescribing limit. And ASAM, has put forth recommendations for, what we feel would be, our members feel would be an appropriate start, which would be over a 2-year phase-in, increase the limit for prescribing physicians to 250 patients per year, and then up to 500 patients in year 2. Prescribers seeking an increase in patient limit must satisfy additional addiction treatment training requirements approved by SAMHSA that covers prescribing, counseling, treatment and planning, drug testing, pill recall. This training would be in addition to the buprenorphine certification required for the 30/100. Prescribing physicians who are an expert in treating addiction as evidenced by board certification, as well as the American Board of Psychiatry and Neurology and Addiction Psychiatry shall not be required to obtain the additional training with board certification. And additionally, recommend that there be a follow-up study on the impact, and this goes to what Dr. Volkow talked about, a follow-up study on the impact of increasing the limit on diversion rates and treatment access, specifically after 2 years of the increased prescribing limit. HHS, in consultation with the Drug Enforcement Agency and CDC, should determine what impact, if any, the increase in access to opioid addiction medications has had on decreasing deaths due to opioid overdose, decreasing diversion rates, and improving patients' access to the Food and Drug Administration approved opioid addiction pharmacotherapies. So expanding the prescribing limit for qualified providers can have an immediate positive impact on these patients as far as adding access. An opioid addiction patient access to a clinically cost-effective addiction pharmacotherapy. However, it needs to be a part of a larger, longer-term effort to assure safe prescribing of opioids for pain, alternate pain therapies, and a number of other things. But addiction education, along with the ability for us to write for buprenorphine, is important. Treating addiction, it takes more than just a prescription pad, and I think that our patients who get this treatment understand that, and I think that it's something that when I first started in this business, I started as an emergency medicine physician, seeing patients that I couldn't help in the emergency department, and found that I really disliked my job because I wasn't able to help patients in the emergency department, and we were a part of that problem. And after training in addiction medicine and now seeing all of our pregnant patients that are addicted to opioids in our county that go through my clinic, having to turn away an average of 1 a week because of my limit on buprenorphine, and having to send them to the methadone clinic or to another county to obtain their buprenorphine. This really can't wait. We have, while we've had this conversation, we've had 2 people die in this nation from overdose, so I think it's important for us to understand that timing is really, really important. My patients have stories like these all day. Patients complained about care in the emergency department. I have patients who come in and have lives and have families that have been regained. And so I think through appropriate efforts of training and educating and availability of this medication, we can completely change the pathway of this disease for this country. Thanks.
Well, thank you all. Let's have a dialogue here. What I'd like to do is to identify the barriers to greater availability. I'd like to get your thoughts on, and they've been mentioned, a number of them, but I'd like to kind of go through some of them. And then talk about a strategy. Could be a legislative strategy where needed. I don't know how much it's needed. That's one of the things I want to talk about, actually, as to whether there's authority already to waive the 100-patient cap that exists already without legislation. And if it's not an effective waiver that exists to go above it in law, then Senator Hatch and I will do our best to deal with the law, but there's an awful lot that can be done outside of the legislative process, and maybe everything could be done outside of the legislative process. We've got Medicaid, we've got the Affordable Care Act now, which may change this picture in some ways. And so I want to kind of go through this. First, let me start, I think, with Dr. Volkow. Let's go through some of the, let's start to make a list, which a number of you have already made orally and a number of you have written about. What are the impediments to greater access to, and let's focus on BUP. So let's start with the patient limit. You've done some incredible pioneering work, Dr. Volkow, which I'd love to talk to you about. I think it may inspire more physicians, if they heard about it, to go into treatment. And the whole shortage of physician issue is much deeper than just a cap on patients that frustrate those physicians who are willing to go into it, but there's stigma issue, there's a training issue, there's a number of reasons why we don't have more physicians. But let's start with the cap, if we could. Let me switch that around. I've been switching around all morning. Let me stay in that mode. Let's talk about the number of physicians willing to go into this practice, and as to how we can, before we get to the caps issue, how do we encourage more physicians to go into this practice? Is it something we ought to try in medical school and training? Is it something where there's a bureaucratic, and I've heard this from a number of doctors, a bureaucratic problem that in order to get certified, you got to go through a process? Is it a fear of the DEA swooping down on your office? Let's go through that issue, number one, and we'll kind of go around the table, get some thoughts on that, and make up a list, because at the end of this list, I want to talk about a strategy for addressing some of these hurdles, okay? So let's talk about that first. We've heard a lot about all the advantages of BUP. We don't have to, I don't think, go into more of that now, although if there's something that needs to be added in that area, we can add it. But let's talk first about the question of the shortage of physicians.
Yeah, no, and I thought about deeply on that particular question. I mean, as a physician, I'm trying to understand why is it that it has been so very difficult to bring addiction as a mainstay of the healthcare system, even though the evidence now clearly shows that drug addiction is a brain disease and that it can be treated, and yet the healthcare system has not embraced it. And I think one of the most important factors why it is not being incorporated is education. It may sound simplistic, but I don't think it is. As in medical school, and many researchers have looked into it in great detail in the United States, there is very little exposure to the education of how to screen and treat substance use disorders. And one of the things that makes a physician, and this I've been told many a time, I don't want to ask questions to my patients about their drug use, because if they tell me that they are taking drugs, I don't know what to do. So if you as a physician feel that you don't have a path forward in terms of being able to help your patient, you are not going to actively seek an intervention or get the information that's necessary. So one of the very doable things, and we've been working to try to create curriculum for education on the screening and treatment of substance use disorders for medical schools. And yesterday, I actually, so starting with medical students so that they can inquire about substance use disorders in their patients. And one of the things that has highlighted this problem is, which is a very unfortunate, this massive amount of drug use on opioid medications that some call epidemic. I'm careful because people jump at me and say, don't say epidemic. Well, whichever way you want to call it, devastating, is created by the healthcare system. And it is created by the healthcare systems, of course, not intending to do ill, but because they did not know better. And yet the evidence, the knowledge is there. We have not implemented the treatment. So to me, this is really an urgent to demand education on screening and treatment of substance use disorders. As speaking with all of the experts on educational curriculum, they say, how do I make the schools do it? Because they say, we have such a huge curriculum that we cannot increase it further. And says, if you can get questions that relate to substance use disorders in the exams that medical students have to do in order to get their licenses, then it will incentivize the medical schools to do it. Bring it to specialties. I was yesterday at the graduation ceremony. I was speaking with a graduate ceremony for psychiatry at New York University, which is my alma mater, and I was telling them, as a psychiatry resident, specialty of psychiatry, where most of my patients had substance use disorder, I was not ever trained on substance use disorder. So the need of educating physicians also in specialty treatments is a crucial one. And if they were properly educated, we will not have the severe problem that we have on prescription opioid addiction that we currently have. I think that is probably one of the most important things that we can do. The healthcare reform will significantly, and access to insurance, increase the likelihood of physicians, if they are properly trained, to be willing to address screening and interventions for their patients with substance use disorders. In the past, if you were not being paid for an intervention, or because the patient did not have insurance, you were not incentivized to actually do it. And a third one that I'm going to put in the table, because I would be not doing the field, I wouldn't be doing my job, is that while we have buprenorphine, which, as you have heard, has many advantages, and we have methadone, those are two medications. We need more research in alternative forms and alternative treatments, because it's like when you go to a doctor and they give you an antibiotic, it's not that he's working with one or two antibiotics. There are several, so you can have different alternatives. Not every patient responds to one treatment, so the ability to provide more than one treatment is another extremely important area that requires actually investment, not just from the government on developing the research, but from pharmaceutical industry. So this has been brought up on several occasions, the need to get ways of incentivizing pharmaceutical industry for the development of medications that can help us solve the problem of opioid addiction, and medications that can help also prevent their overdoses. So to me, these are three things that are crucial. One, education of medical students. Two, education of specialty pharmacists, nurses. Second, clear-cut remuneration of physicians for their participation on the treatment and screening of substance use disorders, and awareness to incentive models that will engage pharmaceutical industry so that we can have more than the very few medications that we currently have for the treatment of substance use disorders.
Okay, thank you. How about, let's hear from SAMHSA on the issue of more physicians. We're going to go to other issues, but let's start with this issue.
While we are looking at the issue, you heard from Dr. McCants-Katz. We agree with Nora. We need to have more education at the medical school level, and that means getting involved with the training institutions. University of Pennsylvania, and I was just in Puerto Rico. One of the medical colleges there is starting to offer certificates in addiction to medical students so that they start medical students off early in the process of developing this expertise. As I mentioned, we recognize that the 100-patient limit is something, the 30/100 patient limit is an issue, and the department is looking at that from a regulatory point of view, which would augment or offer a parallel approach to a legislative point of view, depending on which could...
would that affect the number of physicians that we have if we raise the caps? Is there a...
That would not affect the number of physicians.
Let's get to the caps later then. Let's
okay,
focus.
So the number of physicians is, the effort is to get medical students to be aware, to get pain docs to be more, people who are treating pain to become more aware of the rational relationship between their efforts and the therapeutic options that exist when patients develop, as we heard from Mr. Kaur, his description of what's happened to his daughter, and we heard from Dr. Kitzmiller that in pain management, there's a risk for the development of dependence. But then those very practitioners don't seem to be aware of solutions to some of those problems. So we need to do a better job of that. We're using our PCSS model to help docs become aware and knowledgeable.
What model?
Our PCSS, our physician clinical support, mentoring, getting docs to be more comfortable with the medications. We don't the current model of training doesn't actually imbue physicians with sufficient knowledge of pain meds, despite the fact that we have a lot of pain meds at our disposal. So part of the issue is making a more concerted effort to train physicians about pain meds and their limitations and their utility. We can anticipate a growing problem because we have the baby boom population growing older, so we're going to have more people with joint problems and degenerative conditions, and so this pain issue is not going away. As others have pointed out, since we're at this watershed period in essentially the physiology of human beings in the United States, we need to
that goes to the question of reducing the number of people who become addicted.
This goes also to the question of the practitioners who are trying to respond to the pain as a presenting symptom, that you need to be aware that if your intervention has associated with it a risk, and if we can do early intervention, early assessments, that those risks can be evaluated, and therefore the interventions can be strategized. You don't have to wait until you're nearing an end-stage condition. You can be more sensitive to the adverse reactions associated with pain medication.
Great. Yeah, Mr. Botticelli.
A number, while I agree with what folks have said, this has obviously been something that's been important to our office, and as we looked at the issues, and as we've heard today, I think that there are some issues that we have to identify beyond just increasing the cap and the number of physicians trained. I think we heard.
I know that, but I want to do this issue by issue.
Sure,
I want to do this in a way which will. So anything that affects the number, that could increase the number of physicians, is what I want to focus on first.
No, that's where I'm going with this, because I think that part of what happened, and I think what you heard from Ms. LaBelle, is that, if there are opportunities to focus particularly on our community health centers, which are really the vectors of a lot of both primary care services for people, as well as expansion around community health centers, providing that training and technical assistance for them to do this kind of also dramatically increases the number of physicians trained. So I think, quite honestly, there are federal opportunities that we can talk about to look at how do we use the regulatory, contractual authority, and some other authorities that those of us in the federal government have to really ensure that people who are coming into service, particularly in some of our community health center settings and other places, are adequately trained.
This is a very important point on community health centers. Let's stay on that just for 1 second, because we have now a huge growth in the number of community health centers. That was part of actually the Affordable Care Act that happened. I don't have the number in my head as to how many we have and how many we're going to have, but it's a huge expansion. And the question is there any obligation? So I'm glad you mentioned it. Does anyone know offhand how many community health centers, even about? I'm not about. Does anyone know the number? Okay.
No, I'm sure someone could Google it in a hurry.
Yeah. Okay, all you Googlers out there, have a competition. Who can find out how many community health centers we have approximately and how many we're going to have? Let's just talk about that. Is there any obligation now on community health centers that are federally funded? I think they're all, the ones we're talking about are all federally funded or have federal funds. Is there any obligation on them to look into having people on their staff who are certified? Any current obligations that anyone knows about?
To my knowledge, no.
Should we consider that?
I think it's worth examining.
Okay, so let's put that on our list as a possibility, as to an obligation to be able to, and these are really, this is a really big issue. You have an additional item on that?
Sure. The other piece that continues to astound me is that too few of our specialty treatment programs are offering medication-assisted treatment. And I think there's opportunity for us to look at federal oversight agencies if we really believe that medication-assisted treatment is the standard of care, that it reduces overdoses, and we know all this for a long time, I quite honestly don't think that any federally funded treatment program should view the integration of medication-assisted treatment as an optional activity. And we also have many treatment programs out there who are actually not admitting people who are on medication-assisted treatment as part of their recovery support services. So I think there's also additional opportunity to look at, one, increasing the capacity of our existing Jackie did not do that on purpose. I saw that. She did not do that on purpose. But I do think that there are, we have opportunities to look at immediately. I think this is a really low-hanging fruit of looking at how do we increase the capacity within our existing specialty treatment system to increase the number of physicians trained and to also offer medication-assisted treatment and to not to deny clients who are on medication-assisted treatment access to all the other therapeutic and recovery support services that we need.
Since HIV has been mentioned and hepatitis, under Ryan White, there's an obligation to receive Ryan White funding to do mental health and substance abuse treatment. That should include medication-assisted treatment. FQHCs are supposed to provide behavioral health services also, but again, that obligation is not well assessed. When we look at the prevalence of substance abuse treatment under FQHCs, it's actually de minimis.
All right,
so Ryan White has, in the CARE Act, has a requirement for behavioral health intervention, and that should be included.
Okay, that's a great suggestion. That's going to all be done without any legislation as well. Dr. Kitzmiller, did you want to add something there?
Yes. You know, sometimes I think that it was easier for me to fix somebody's aortic aneurysm than it is to start them on Suboxone in the office. The amount of paperwork and the concern of being the DEA just coming unannounced into the office is bothersome. The need for pre-authorization from insurance companies is a difficult problem that usually takes 48 to 72 hours. In some people that are in the middle of withdrawal.
Who gives the pre-authorization? Each insurance company?
Yes.
So if you have more than one insurance company you're dealing with, which is the case, you have to get, in many cases, pre-authorization from more than one insurance company.
Yes. And for example, I have a small office and a small staff, so it's not like I can just go tell somebody to do something. And for example, in the state of Michigan, people can be in Medicaid for a year, but then they have to choose a specific policy, and there are like now 6 or 7 or 8 different Medicaid policies that they have to choose from. And some of them pay me and some don't. So I probably see half of those patients for free. And when you ask about, you know, trying to get more physicians to see this group of patients, if we're seeing half of them for free, that's a deterrent, frankly.
Now, under the Affordable Care Act, I don't know who to look at this, I believe, is there not a requirement under Medicaid that the mental health and substance abuse be included?
Yeah, the 10 essential benefits includes mental health and substance abuse services.
So that may change for Medicaid under the Affordable Care Act. Now, is that true with Medicaid?
I think part of the challenge here, particularly as it relates, and ASAM actually did a study to look at this issue, is, there's a tremendous amount of variation around Medicaid benefits on a state level as it relates to access to medication-assisted treatment.
Will that still be true after the Affordable Care Act kicks in?
It will. I mean, part of Medicaid is that.
And can that be corrected from a regulatory perspective?
I think we'd have to look at that to see what federal authority exists around CMS to do that.
So to that, one of the biggest issues is that in 2008 we had parity pass, and then when the regs dropped for parity last fall, they didn't include Medicaid. So they put in the regulations that was to commercial plans and plans in Medicare, but not to Medicaid. So they specifically excluded the requirement for states and payers to allow for the appropriate access to medications and treatments.
Who did that? Where was that done last fall? You said by whom?
By here and HHS. administration.
Someone give us the history of that?
Well, HHS is not the only game under those regulations. In fact, you've got Treasury and Labor actively involved in that. So we have to generically refer to it as the administration because
Just repeat this because I was a little bit distracted. Something came out last fall which left out the medication.
Correct.
Repeat what that was.
So parity. So when parity came, it basically
Parity in where?
parity to the availability of treatment for mental health and substance abuse services, and so
That parity was in the Affordable Care Act, was it not?
correct.
Okay.
And so that came through in 2008. However, the regulations for how that was to be done were not written and placed into action until last fall. And then so when they came in last fall, they were written to specifically exclude the Medicaid beneficiaries. So what the parity tells us it was meant to do was to increase the availability and the expediency with which those directed treatments could be levied on patients, so that if I have a patient that walks in on a Wednesday, they walk out on a Wednesday with a medication no differently than if they had diabetes and needed insulin, no differently than if they had hypertension and needed a blood pressure med. That, however, did not and still hasn't been proven in court. It's working through the regs for that because a lot of even the ones under the regulations still haven't started to meet that criteria, even though that's in regulation and in law. But that's a huge barrier because the requirement, as stated very appropriately by Dr. Kitzmiller, I have a 72-hour window sometimes to get my pregnant mom in withdrawal medication. And so we end up having to send them to the hospital to stabilize them on something I could write a prescription for in the office. And that happens in a number of different places. So the heterogeneity of the way that it's been applied at the state level is also a significant barrier, as stated by Dr. Clark and Dr. McCants-Katz, in that Michigan does it one way, Indiana does it another way, Ohio does it another way. It's 1 year, it may be 2 years. There may be no limit on the amount of time you write it, but there's a limit on the dose you can write. There may be no limit on what dose you write, but there may be many barriers that you have to go through paperwork-wise and phone call-wise.
Yeah, but what we want to do here is to
But
we'll
fixing
have to
that
identify.
would, yeah.
But if we could have just in in each state,
Yes.
if we could just have all insurance companies and Medicaid be on the same page.
Exactly.
I think the fact that there may be differences between states is a bridge too far.
Well, I'm just saying
these
these are the
and I think it's unnecessary probably, although there are circumstances where it'd be helpful to have a federal uniform policy on all these provisions. I think if we could do it in one state. Now, how do we then do that? Is that the insurance companies are regulated, I believe, both by federal government and by state. Is there a way, is there not an implication in the Affordable Care Act that there will be medical assistance provided under that act? And does that not cover Medicaid in that act?
It does, but the regulations that came in afterwards did not.
Now let's get an explanation. Are the regulations still open or are they final? What form are they in? Are they in proposed regulations, final regulations?
So final regulations have been released by HHS as it relates to private plans.
Okay.
With the understanding that there was going to be further clarity from CMS as it relates to the application of the parity rule for Medicaid managed care plans.
Okay.
So I think there's opportunity to have discussions with CMS about what that further guidance looks like.
That's very helpful. I think that's the right direction then, is to talk to CMS about further implementation of the Affordable Care Act's parity requirements, right?
Senator, the other issue at play here that I think Warren's mentioning is the tremendous amount of stigma that's still associated with medication-assisted treatment, and particularly how that plays out at a state level, because I think the other opportunities for education is not just at the medical community, but at the legislative level as well, particularly with governor's offices and state, because we still see, unfortunately, a lot, some governors, even in the midst of a heroin epidemic, as well as legislators attempting to really limit access to medication-assisted treatment. So it's not just about the insurance issues that limit it. It's also. So part of the work of our office and others here is how do we provide education to some of our state policymakers to make sure that they know that these medications are both effective and cost efficient. So, because I think that's a significantly limiting factor that relates to Medicaid policy at the state level is by what governors and state legislators think about medication-assisted treatment.
Just to answer your question fully on how do we increase the number, we have done two things that have increased the number of prescribing physicians in our region. When I first started, I was the only, and still am the only board-certified addiction doc in our entire system of care, which is 11 hospitals and a third of West Michigan, population-wise. And we had 30 primary care doctors who had a waiver. Only 2 had ever written a prescription for buprenorphine. So I called the other 28 and the 2 that had only written a couple of these prescriptions and asked them why it is that they felt uncomfortable and what would make them more comfortable in writing this. And the answer was pretty consistent, and it had to do very much with, it wasn't so much about the medication, it was about the disease and understanding how to treat the disease by itself. It's scary. What is required? How do we do it? What are the guidelines? And one of the things that increased that 30 in writing the prescription was being able to have local access to an expert to help them with these patients. And so just by adding a telephone call capability, we've now doubled those docs that are writing it, and patients that I see, I can stabilize, hand them off, knowing that they can always call me to get an answer. So connection with a local expert has really been a very stabilizing and appropriate pathway, and it's been adopted by a number of other places. And then the other one was having a community capability to show them how to store and track patients and medication so that the fear of the DEA aspect wasn't such a looming problem. And that was stated, again, by all of the physicians that I spoke with, was the fear of being, quote, raided by the DEA for writing buprenorphine. And I do have to say, I review cases for the state of Michigan for misutilization. The last 4 that have been brought to me are buprenorphine doctors. And 3 of those are not doing anything out of the ordinary, to be honest. When you look at it, standards and care, 1 was. But when I asked them why I got, not opioids, so the person who prescribed the most opioids in the city as one to review, they couldn't give me an answer. So some of their fear is founded in truth of focus, in that you really are a little bit highlighted as someone to be evaluated and treated. But helping them with the toolkit of this is how you do it, this is what the form looks like, this is how to maintain it, has been helpful, and physicians feeling more comfortable with this.
What about, that's very helpful. And I think the DEA aspect here needs to be addressed.
Can I just add a little bit to that DEA aspect? To ultimately increase the number of prescribers, which I think is what you were asking about, in order to create a prescriber, that doctor has to take an 8-hour training, and there's the course we heard about from Dr. McCants-Katz, which is this hybrid online 4 hours live. But those trainings themselves, without enough trainings, it's going to be hard to make the doctor even eligible to prescribe. So one opportunity.
Without enough
training. So we need more training programs. So for example, if SAMHSA were to fund trainings around the country, more doctors would then become eligible. But once you've got a doc who takes a training, what happens is they've taken the course, they're now, maybe they apply for their waiver, they're now eligible to prescribe. What may happen in many cases, before they've ever actually seen a single patient, they get a knock on the door from the DEA. Just simply the fact that they have their waiver to prescribe, there is an automatic visit. And when a doctor who might have been on the fence about prescribing gets a visit from the DEA, what really comes to their mind is, gee, this is not something I'm going to want to do if I'm going to have the DEA coming in and looking at my charts. Nothing like that occurs for doctors who are treating pain, even with aggressive quantities of opioids or in combination with other sedative drugs. There are no automatic visits for those doctors. So I believe it was written into Data 2000, this requirement for a mandatory visit from the DEA. If we could eliminate that, I think would help us increase the number of doctors who actually start prescribing. But a related question or a related issue in terms of increasing the number of...
Excuse me for interrupting. Is that the visit before the waiver is granted or while the application is pending or what?
It can happen at any time. It's after it's been granted, but it can happen before you've ever seen a patient. And then just another significant barrier to increasing the number of prescribers is the fact that we don't let nurse practitioners become eligible to prescribe. I think for an organization like Phoenix House, which is a nonprofit organization around the country, in parts of the country it's very difficult to find physicians, and hiring physicians for a nonprofit organization, it's expensive. And if we were able to use nurse practitioners, it would make it much easier. Nurse practitioners are allowed in most states to be prescribing Schedule II drugs, which have a significantly higher addiction potential and overdose risk than buprenorphine.
And I understand that nurse practitioners are allowed to participate under doctor supervision in methadone. Is that true? Does anyone know? Methadone?
Under doctor's supervision, yes.
Under doctor supervision.
Yes. And
But that's not true with bupe.
It is true with bupe, and this is
That
the
a nurse
Massachusetts
practitioner
model.
can actually
Not prescribe, but they can do everything short of prescribing.
Can they? Okay.
Everything short of prescribing. Only physicians can prescribe. I just want to say a couple of things. So we are looking at these issues of barriers to
Be more specific. Nurse practitioners. Let's go barrier by barrier.
okay.
Nurse practitioner.
Nurse practitioners can only work under the, cannot prescribe, but could do any other part of addiction treatment, of which there are many parts, short of prescribing for the patient. You need a physician
But they
to
can't prescribe the,
They can prescribe OxyContin.
They can prescribe pain medications. They can prescribe controlled substances that are opioid analgesics for pain, but they cannot prescribe buprenorphine to treat addiction.
Does that make sense?
I think that...
Well, let's discuss it.
It does not make sense.
I think that... I think that nurse practitioners have a lot of training, and I don't, myself, don't see why they cannot prescribe, except that for the law. But I do want to say that...
Well, I know, but the law is something we wrote. In order to get a law passed, we had to make compromises, which we hated like hell to make, frankly, but we had to get a law passed. So
in rural areas, there often isn't anyone except a nurse practitioner or a physician assistant, and the physician circulates through these areas at different times during the month, but day to day, it's the nurse practitioners and the PAs.
Okay, I mean, that, I think, is one area where we do have to get our law changed.
And I'll make a point, though, too, also, because I think that there's no real justification of why we're treating differently buprenorphine versus opioid medications. But we have to also realize that, in a way, we also have perhaps opened the door too expansively for the prescription of opioid medications. So we have seen this dramatic increase in prescription medications because we have not properly implemented training also on the side of screening and treating with opioid medications in nurses, physicians, pharmacists. So as we discuss this dialogue, I think we have to make it clear we don't want to make the same mistake that we did with the pain medications. Let's learn from it and involve the nurses within strategies that ensure that they are properly trained in the proper prescription of buprenorphine, but always highlighting that. Because
can you combine under the supervision of a doctor to the prescription piece? In other words, is there any example where we allow a nurse practitioner or someone else to prescribe under the supervision?
In many states,
Depends
that
on the
does
state.
exist.
Yeah.
Is there any reason why that is not a good solution, at least as an interim step?
No.
Well, ASAM definitely supports, that aspect of it in the sense of allowing, PAs, nurse practitioners to prescribe under the supervision of a directing physician, as it is stated in many states. I think we have to remember the training capabilities. We're concerned currently about physicians misprescribing these medications with a minimum of 11 years of training and looking at, and so we have to extend that worry to someone who has, a third of that training. I have nurse practitioners and PAs that work in my office, and my office doesn't work without them, period. They know my patients well. They tell me when they think we need an increase or a decrease in medications because they've gotten to know them, but we have that dialogue. The capability to have the dialogue is safer for a patient than to have someone who even a physician by themselves sometimes, to be able to have that dialogue is very helpful. So I think that supervision piece, and this has been discussed at many levels within the ASAM
This is something which SAMHSA has taken up. Now, I interrupted you, Dr. McCants-Katz, I believe.
Sure, I just wanted to, two things. One, I think we can get more physicians prescribing if we start at the level of medical schools and residency training. And if we can convince the National Board of Medical Examiners and the American Board of Medical Specialties to include questions on certification examinations, licensing examinations, related to addiction and its treatment, then doctors will become skilled in this area.
Thank you.
And the second thing I was going to say was that we at SAMHSA are looking, as I mentioned, with our federal partners about the issue of observed practice. So we think mentoring
Is that what that's called? What is observed practice?
Observed practice would be where someone comes to my practice and they watch what I do and they learn about how I undertake buprenorphine treatment. So for a lot of people, that's for a lot of physicians.
That's the mentoring piece?
That's one mentoring piece that doesn't happen right now, but it could. Before I came to SAMHSA, I had a grant to do that when I was in Virginia. The mentoring program that Dr. Waller is talking about is one that involves interacting with physicians, but generally short of going to their practice and observing. So we think observed practice could be an important
That's part of a learning for doctors to be able to go to that, and that's right. To facilitate that.
Correct.
Now, am I pronouncing your name Civilli?
Thank you. I just wanted to mention that Dr. McCants-Katz mentioned we need to reach out to the National Board of Medical Examiners, the medical exam people, to develop questions. ONDCP reached out to the National Board in 2010, and we worked with them to understand their process to do a review of the exams to determine if there were sufficient elements addressing substance abuse across the board. And it's a multiple-year process, and I believe it's in the last year. They did convene experts across the government. We identified doctors to identify the elements. So that piece is taken care of. I just want to say that.
We hope. Okay. Anyone else want to jump in?
Can I comment on the nurse practitioner piece? I mean, I think just opening it up to all nurse practitioners may be a little worrisome for folks with the expertise, but if you're talking about nurses that are working in the field that are doing addiction medicine work, that are committed to it, and maybe having them go through a certification. There is a certification for nurses for addiction as well, so similar to ABAM, so your NPs could be CARN AP certified, and maybe working under the direction of addiction physicians to give a additional support system. Just some thoughts to that. And then as far as you were talking about insurance plans, Medicaid's an issue, but Medicare is also an issue. There's 35 plus Medicare plans out there, and they all have different restrictions and different prior authorizations that occur with buprenorphine, some of them to the point where they want a urine screen within 7 days of the PA going out, and they want documentation that the person's gone into counseling, and they want copies of the screen and copies of the counseling. And we don't see that in any other disease entity, so it really inhibits the ability to get folks their medication, and patients can end up in withdrawal for days because of these restrictions.
Could you, on just that narrow piece, get to me the list of the requirements
Under Medicare?
Under Medicare,
Sure.
which are not
Yep.
in other areas? Is that because there's 35, what is 35 numbers? Is that insurance
There's more than
companies?
35 different plans under Medicare, insurance companies, Silver
Does that
Script,
mean insurance
Humana.
companies? Okay.
Yes.
Okay, that would be
And they all have
very
different-
helpful to do that. Yes, Dr. Kitzmiller.
The other problem with the Medicare issue is the so-called donut hole, and because of the cost of Suboxone for 16 milligrams a day for a month is in Michigan around $700 and some. So patients that are on Medicare and they're in their donut hole, they're all of a sudden paying $700 and some a month, and most of them can't afford that, and that's a serious period because they often relapse during that period.
And that one, I think we cut that hole in half roughly, didn't we? And we're going to cut the rest of it. 3 years later, we have a plan, not a plan, I think it's actually in the Affordable Care Act, to cut it in half, I believe, by a certain date, maybe immediately, maybe this year and then 2 or 3 years down the road. Okay, anything else on the question of increasing the number of physicians or including nurses nurses in that, under supervision, anything in that area before we move to the next question?
So I'll just tell you that at SAMHSA, we've started discussions with 2 schools of nursing, UCSF and Georgetown, so bicoastal, and they're quite interested in developing programs that would specifically train nurses to give them expertise in this area.
Okay, now let's talk about the next one, and that's the length of time. Someone put it very succinctly, which is, how long can the treatment last? I guess it would be, now let's go to the patient limits. Does anyone disagree we ought to get rid of the 100? First of all. Does anyone think we ought to get rid of limits altogether and just say, hey, there's no limits on diabetes? Why should there be any limit here? Does anyone want to argue for no limits? Then the question is, if there's going to be a limit, I'm not sure I understand the logic of it.
Actually, I would argue for no limit.
No limit.
As you said, we don't have limits on the number of people with diabetes that you can treat. I don't believe that we should have limits.
Okay.
But I want to echo something that Dr. Volkow says, what I think that warrants is I think that we need to obviously look at opportunities to expand access, but we also want to make sure that we're doing this in a quality way, right? So this is not just that in some respects, that we follow in some respects what mental health treatment has become in terms of just pill administration and not looking at the comprehensive quality of care issues. So I think, kind of from a administration perspective, while we're supportive of looking at opportunities to expand access and looking at them multiple ways, I also want to make sure that we're doing that in a way that ensures quality care as well. And I know it's a balance without violating the spirit of Data 2000, which was to not have this heavily regulated medication like we do for other pieces. So I think there has to be a balance here between looking at how do we expand access, how do we ensure a level of quality care that's happening, and again, not putting in place regulations that this legislation was never intended to put in place.
Do we do that with methadone?
I mean, from my standpoint, methadone obviously is one of the most heavily regulated medications that we have. Clients have to go to,
No, but in terms of how many patients a clinic can handle.
No.
There actually are some CARF standards that cover the number of patients per physician that are required in within a methadone treatment program. And so you cannot go above 300 without having another physician for the standards that are applied there. And that's been looked at over and over as far as risk, and they did find an increase in risk of overdose if you go above that number. So there was some data on that in the mid-90s.
Is 300 a limit on methadone?
Well, there's a 300 limit on a program. At that point, you need to have access to a second physician in order to increase the number.
Is that 300 per physician in a clinic?
Yes.
Mm-hmm. Why not have a similar number than in a BUP physician?
We would advocate for that, but that's...
I mean, there's a symmetry to it at least. If there's any logic to having a limit.
Well, there's a background concern. We are dealing with the issue of addiction, not simply medication substitution. So the rationale that you confronted in your legislative role was that there was a fear by your colleagues of recreating pill mills and opioid, quote, methadone programs, which is why they you negotiated the compromise in the legislative process. The same process would evolve, even from a regulatory point of view. And there are the concerns of if the practitioner cannot manage the caseload adequately and facilitate the provision of the kinds of services that nurse practitioners are providing in Massachusetts, then the risk of diversion, the risk of comorbidity in terms of other drugs like benzodiazepines, et cetera, starts to go up. And while the system has tolerated the modest diversion that has occurred with buprenorphine because of access issues, once those issues disappear and if the diversion continues, then we lose the argument that the only reason there's a diversion is because there's that lack of access. And then, of course, then you start getting the backlash, the political.
What other reason is there
administrative
for
backlash.
diversion except lack of access?
I think that is the main problem with diversion. I think these...
Main cause.
Right, the concern...
Probably mean the main cause of diversion?
Well, yes, if there were greater access, you'd see, I believe, much less diversion. I think the issue of diversion is very important, and it is something we should be concerned about. But what you need to worry most about with diversion of opioids onto a black market is whether or not that diversion is leading to people using the drug recreationally, creating new cases of addiction, or is that diversion leading to overdose deaths? When it comes to buprenorphine diversion, it does not look like it's a drug that's being used recreationally by people who are opioid naive and then creating new cases of addiction, and it is not exacerbating our overdose death problem because it's quite difficult to overdose on buprenorphine. I think the issue of safeguards is important, but if we have safeguards on buprenorphine or barriers on buprenorphine that don't exist with regard to pain medications, it's very difficult to treat this disease. If someone can easily march into a pain specialist's office and get as much OxyContin as they want, their insurance is paying for it, and they can't access buprenorphine, or if they can easily get heroin on the street, it's very difficult to treat that individual. So I'm worried about having the perfect be the enemy of the good here. I do not believe we should have any safeguards for buprenorphine treatment that do not exist for Schedule II opioids.
No, and I mean, I agree with my colleagues, and my concern is that I think that our safeguards for how we're administering other opioid analgesics are just too broad, and as a result of that, we are over-prescribing in this country and driving a lot of the problem of addiction to opioid medications and overdoses. So we should not imitate something that is creating a very bad problem. And one of the things, for example, that we have to be cogent is the data that exists. And in Europe, for example, buprenorphine is widely used as an analgesic, not so much in the United States. And in Europe, it has been associated and it has been of concerns of overdoses from buprenorphine, even though it's overall much safer than other opioids. Because what happens is many of these patients not just take buprenorphine, but they may take benzodiazepines or they may combine them with alcohol. So from the European literature, there has been emerging reports of deaths from overdoses of buprenorphine where the regulations for the treatment of pain are not what we currently have for the treatment of opioid addiction in the United States. So I think we need to learn from past experience to avoid those mistakes. And that's why it is not fair to treat one drug differently from the other. We need to recognize that perhaps in the other drugs we have just been extremely lax.
Well, that may be true, but isn't there something to be said also for the argument that in the case of one drug, it's a way to block the problems which are created by the other drug?
You know that...
Should that be at least treated, huh? No? Well, what's the abuse of bup?
You know, the abuse of buprenorphine, the numbers are not, it can be diverted for high, 95%
for what? I'm sorry?
to get high, for rewarding effects. From surveys, 95% of that diversion is exactly to avoid withdrawal, but 5% is in order to actually have its rewarding effects. Let me just give you a simple explanation about why the use of buprenorphine may not be as simple to manage as a physician for treatment of pain. You come to me for pain. I want to have severe pain. You need an opioid analgesic. I give you the buprenorphine. The pain does not go away because buprenorphine is going very slowly. You are exasperated, or the physician gives another dose. No response. And then no response, they give another dose. No response, they increase the dose. And then this dose is accumulating. And that can result in overdoses. Or the patient themselves are on pain. And they don't really recognize that the effects, the ability of the opioid to cut the pain is going to be delayed, which is not the case for other pain medications where the effects are almost immediately, like morphine. If I give you morphine, it's gone. So this is why education is so very crucial. And the intensity of that education is based on the needs that you require in order to be proficient. So I'm extremely proponent. We are constantly, it's my argument, let's use buprenorphine, it works. It's a non-brainer. But I also see the opioid epidemic, and I said, well, why did that exist? Because we didn't properly train physicians to properly prescribe it. So let's use that knowledge so that we don't make mistakes while creating a system where we can prescribe and patients don't have to wait, and in the meantime, overdose. I mean, that's unacceptable.
Isn't the problem with your approach that while you're trying to find out a way to restrict the use of the pain opioids that are used for pain, you're trying to reduce the amount of abuse of opioids? That can take a heck of a long time, and that's probably an incredibly controversial, complex issue involving all kinds of training, whatever else you got to do to avoid the overuse of the opioid. In the meantime, we're denying half the people who could be benefited from Bup that because there's a possibility that in 5% of the cases that there may be an abuse. I mean, you got a big problem out here, it seems to me, which is the opioid problem, and you got something which will help that problem most of the time. And it seems to me that if you wait to solve the excessive use of opioids for pain, if you wait for that day to come, and I'm all for it, I guess everybody's for that, you're delaying the day when you can use Bup to deal with the big problem. It strikes me.
And it would never be something that I would promote on sort of let's wait until we solve this is urgent and we need to address it right now. The issue is, and again, the question, how do we make buprenorphine much more accessible to patients? How do we increase the number of physicians that are able to screen and treat the substance abuse patients? But how do we provide that treatment in a way that is going to be optimal for patient good outcomes? And they are not exclusive. So that's why, I mean, I have an hesitation saying, okay, it's very hard to determine, is 300 sufficient? Well, it's done in methadone. And see that, and then if 300 becomes a number that actually is not associated with any adverse effect, then go to high, just remove it if you want. But I think that I tend to be cautionary in this situation because you don't want it to backfire. What we don't want is we start to see an escalation of buprenorphine and then we jeopardize it.
Let me ask you, is there a number that you think we ought to start with?
Well, the number of 300 was passed around vis-a-vis the experience that we have with methadone. So I like to anchor myself on something that we have some knowledge. And that's why that number in my brain may be one that I could feel comfortable. I'd like to hear also from other perspectives, but 300 would be a number based on the methadone experience that I would.
Okay, yes.
I'd like to remind us that we have 26,000 docs that have waivers, but only 8,000 docs who are willing to prescribe 100. And so even in our existing paradigm, we don't have 26,000 docs who are willing to prescribe 100 and who are.
We need more docs.
So we need.
Not just the limits.
It's just not the limits. And there's a dynamic. You have to ask, well, what's wrong? What's that dynamic that, in fact, even now, we have essentially almost 20,000 docs who could prescribe 100, but who aren't.
Why is that?
That's part of the point.
Well, that goes to what I had spoken to earlier. There's a fear of lack of knowledge about the disease. There's a fear of the stigma as a doctor who treats the disease. So we talk about the stigma for the patients, and I see it in my patients. They're treated horribly in the mainstream medical field. But then when a doctor takes on addiction as a treatment pathway, you become a, quote, addiction doc. So this was interesting. You know,
in other words, at 30, you're not an addiction doc. At 100, you are.
Yeah, well, that's the way that it gets perceived. And so once it's that, then you see those people. I mean, this is...
Perceived by the colleagues?
By colleagues, by the hospital system, by payers.
How do they know? How does anyone know that a doc has 100 instead of 30?
Word on the proverbial street. But the reality is that, you know, I sit at the high 90s pretty much all the time, right? And I have a small army of primary care doctors that we're trying to hand off patients when we get them stable so that I can continue to see new patients. All of them have the same thing. It's this fear of the disease, it's the stigma of the disease, it's the lack of knowledge about the disease, and it's really all stems from appropriate education. When I give a lecture about the neurobiology of addiction and talk about dopamine and reward, doctors come up to me and ask how can they start prescribing. It's a matter of that education, and that's really key. And a measured approach to this, I think, is In 10 years, if we have no limits, that would be amazing. If in 3 to 5 years, if we have that, that would be great. But the problem is that we don't know what's going to happen if we increase the limits. Immediately, that will gain access because somebody like me could see 200 more people.
Do you favor increasing the limits?
I do, on a personal level and from the ASAM perspective.
Yeah. Okay, I think you were, Ms. LaBelle, you wanted to get something.
Yes, so another concern about increasing the levels is we all know that there's a lot of practices out there that are really practicing outside of safety and are really not practicing with standard of care. And we have patients that tell us these horror stories. They show up and pay their $200 and drop their urine in a bucket and off they go. You take away the limits and you just increase that volume of that pill mill that already exists into God knows what. And then neighborhoods and areas that don't want patients being followed and the neighborhoods are kicking them out. And then what happens when the DEA does get to these practices that are prescribing large volumes of patients and they close the doctor down. And that happens way too much. And what happens to those patients which again become victimized and have nowhere to go because we don't have enough waiver doctors that want to treat them or they don't have anywhere near where they live. And so it just creates this other whole problem. I mean, I think we just need to, ASAM docs that are or ABAM docs that have certification or are treated in a different setting where they have supports and they have other docs to follow back on is great. Having our technical support piece that we have in Massachusetts has been really great because when those doctor practices close, we have a huge network of places where we can call up and we can get patients into care. So they're not in withdrawal and they're not becoming victimized. But what happens when we open the floodgates? And those are hundreds of patients that are out there.
Gotcha. Okay.
At the risk of beating a dead horse, that this concept of backlash by opening the floodgates is not theoretical, right? And so I think we're already seeing state legislators move to put more regulations in place as it relates to the administration of buprenorphine. And because
methadone too?
No, because they're so heavily regulated. It's already heavily regulated. And so, again, I think our fear is that there is this moving, as states have gone to really expand buprenorphine treatment, there has been some backlash because of lack of quality practice, even within 100 patient limits. And so you now have states proposing tighter regulatory control. And my fear is that it's going to actually subvert the entire reason why you passed that legislation in the first place. So if we don't do this in a quality way, and as Colleen was talking about, what is the physician support? What other support does the staff have to be able to do this? Are they doing urine testings? Are they doing counts to make sure that people do this? Are they ensuring that people are getting access to other behavioral therapies? So we really have to, I think, again, it's not theoretical what's happening now around buprenorphine expansion. So we really have
I think everybody at least would agree on the number of docs being increased, but in terms of how much you increase the limit, there's some discussion on that. Whether you have no limit, that's another issue. But nonetheless, in terms of more docs that are certified, I think there at least we can, I assume, all agree that that's a good goal. And I think probably from what I hear, at least some or most of us would agree that the limit should be cautiously increased. And one other thing on the limit, is there authority now to increase the limit? Jackie is,
yes.
I don't know if she's.
Dr. Clark said a little while ago that they have the regulatory authority to
defend yourself. Does the authority exist to increase the limit?
Well, we believe that the Secretary, through regulatory exercise, may be able to increase the limit.
May be able. Can you give us an answer on that as to whether the maybe does? No,
yes, I will.
Could you give us that so we have to figure out, do we need to do that legislatively if we want to do it, or can it be done? And then also, if it can be done, can you give us some hint from the Secretary as to whether it's likely that she would proceed to do that?
Well, we're briefing remember we have a new Secretary, so
I understand.
We're briefing her even as we speak, so this will be one of the issues.
That'd be great.
That
And let us know, would you, on that?
Yes.
That'd be helpful. Yeah, also on the nurse practitioner issue, as to whether we can carefully start including people who, in my book, clearly ought to be included, but I look, I guess, at the epidemic and the success rate of BUP and what nurse practitioners do in other places, and that is what motivates me the most. But the caution is a perfectly legitimate, obviously. You guys are the experts, I'm not. even though we have experts disagreeing with each other, so happily there's some experts on following my instinct as well. All right, let me just check. There's one other thing I want to make sure I get to. We've talked about Medicaid, we talked about Medicare, we talked about insurance, I think. We haven't really talked about insurance. We talked about the Medicare. You're going to get me the headaches with 30 Medicare people, but in terms of a whole bunch of insurance companies having different requirements and that being an impediment, what I think I would need is somebody to give me, to pull out of all those insurance company forms, lay it out for us. Look, we got 20 insurance companies here. This one, and be very specific. This one requires this one requires that. This gives you 30 days. I mean,
ASAM would be happy to take that on and
would
get
you do
to
that?
soon. Yes.
Okay, in other words, so now we'll get Medicare from you, ASAM will do the insurance issue. Okay, Jackie, we got anything else we want to cover? Any other impediments, just in the hurdles to expanded access? We think we want to reduce the hurdles. We've heard some cautionary notes, which are welcome. But there's some other hurdles out there that I have not gotten to yet, and I want to do it before. Well, that can be, in terms of the nurse practitioner, when you get into that issue, the underserved areas issue, you'll look at that in particular. Let me tell you what now let's talk about strategy. Putting aside the legislative strategy, if we need it, which is something that Senator Hatch and I will figure out, if we need it. My hunch is most of this is policy, most of this is getting medical schools active, most of this is trying to change the whole dynamic in terms of being addicted, being something which somehow or other is not something that more doctors should be willing to take on. SAMHSA's website, this is another issue. For doctors who have openings, or whatever we want to call it, what about SAMHSA having a website? You have a website already. Could you put a star next to doctors who have openings or available?
That would be zero.
That would be what?
That would be zero.
No,
Most are full.
no, but there are some apparently. Well, that's okay. If there's zero, fine, but if it's zero, then it's not worth it.
Most stocks have chosen not to be on it, so it's not a complete list of the prescribers that have waivers. It's only those that have chosen to have their name listed. It's not an exhaustive.
SAMHSA list is not an exhaustive list.
No, because the doctors don't have to post their name. A lot of them choose not to because it's too many phone calls and it's too burdensome.
Okay, so
because
there may not be many that would.
They've chosen not to
prescribing,
prescribe.
right.
They've chosen after getting the waiver not to prescribe, so they don't list with us.
Right, but I'm just saying, would there be, if there's any number of doctors who have openings that are willing to?
Well, we would need staff and funds for that because that would have to be maintained.
Okay, fair enough. If you want to take a look at the desirability of it, though, it may not be worth it for the reason that Ms. LaBelle said. There may not be enough doctors who are willing to do that. Let's see what else we can talk about here that we haven't.
I did want to put in there from the education standpoint. I'm working with the Robert Wood Johnson Foundation in conjunction with the Khan Academy, and we're developing a 200 lecture series for addiction, pain, and behavioral health, which will be probably up by April. Available for free on the Khan Academy, which is now developing their basic science side for medical students as well as pre-medical students. If you're unfamiliar with the Khan Academy, it's a Robert Wood Johnson funded website that moved elementary school outside of schools initially, but and allowed for people to do work at home. So we're developing those lectures that are 20 minutes long and dedicated to very specific areas that Robert Wood Johnson will be funding over the next 1 to 2 years.
These are lectures for students or for practitioners?
All of the above. We've actually developed the lectures so that you could take a pre-test, and then everybody from a patient to a specialist could benefit from this, so that the vernacular is the same, so that a patient would be able to learn about their disease, and someone who, I think there are many patients who know more about the disease than the doctor, so the patients would probably start farther ahead than most doctors on this, but ultimately it's meant so that a patient, a nurse practitioner, a PA, a physician, a specialty physician would all be able to gain access to this and have evidence-based, non-biased education placed there, as well as ASAM's own website that has currently the eLive Learning Center, which has a large number of resources available, both for free and for CME fees that are available out there. And NIDA has a number of resources on their website. So maybe coalescing a toolkit, nationally, to be able to say, where do you go get it? Because it can be very confusing for physicians, could be helpful.
Now, how does someone get certified now? So how many weeks?
If you don't have addiction training, a specialty in addiction, you have to take 8 hours of education, and that could be online, it could be in a live event, or it could be half and half, which is one course, one way of doing it. And you mentioned strategies now, and I do think one important strategy would be to have free trainings around the country for doctors to become trained. We know that a very
cost. If you're going to do what?
So if you get continuing medical education credits, you'll be often asked to pay some small fee, but otherwise the SAMHSA supported trainings are free.
Yeah, I'm not, if you're a member of the professional society that's sponsoring the training, because the trainings are all sponsored by the different professional societies like ASAM, for example. If you're a member of that professional society, sometimes you can get the training for free or at a reduced rate, but I'm pretty sure we don't have national availability to free buprenorphine training, and I think that would be something that would be very helpful.
Apparently you do, though. You're saying that you do?
So again, the groups named in Data 2000 have the option to charge, so I can't speak for every group, but I can say that the ones that are involved with the PCS, the Physician's Clinical Support System for buprenorphine, those data waiver trainings are available at no cost.
And available around the country?
They're available around the country. We have the osteopaths doing the more rural trainings, and we have the American Academy of Addiction Psychiatry doing the in-residency trainings.
Right. So the trainings, certainly there are free trainings happening around the country, but we don't have the ability for any doctor who wants to get trained today to necessarily have access to a free training.
If they choose to take an online course, I believe they have to pay for those.
That's right. So if you wanted to get trained today, unless there happens to be a free event sponsored in your area, and I don't believe we have enough of them, you can't get the training. So I think we need quite a few more free trainings.
How much does that cost, that online?
It can be about a little under $200.
And that could be an impediment?
Yeah, there are a lot of doctors who will take a course for free CME, but they're not going to pay for it, unfortunately.
Okay. How much money do you have any idea that, how much does that bring in a year?
Well, it doesn't bring anything to SAMHSA. It brings money to the organizations, to ASAM, to AAAP, to the osteopathic groups, and
you provide the website?
We do not. This is done through the data organizations. We do not have anything to do with the trainings for which they charge. We don't have anything to do with that.
Each organization has their own website?
They do, and they can charge whatever they wish to charge. And my understanding is that, at least for one of the organizations that I was involved in, it's a significant source of revenue.
Okay, so that's one of the questions then, as to how, putting aside what currently exists, how can we expand the availability of that training and make it simpler and more available?
That's right. It's really important because we know a small percentage of the people who get trained actually wind up prescribing. And I've heard some say, well, why are we wasting time training doctors if such a small percentage wind up prescribing? But I think actually the answer is we need many more trainings if only a small percentage wind up prescribing.
So the question, I think I assume we all would agree on this, that we would like greater access to people who are willing to be trained?
Yep. So let me...
Fair?
Yep. Well, and again, I think, SAMHSA and HRSA both fund what's called the Center for Integrated Health Solutions, right? And the main goal of this was to look at how do you promote increasing capacity for substance use services within primary care. And again, I don't want to, but I think it's worth looking at the activities of that center to say, are there opportunities to increase both training and some of the technical assistance that we.
But right now, the way the law is written, it has to be one of the groups named in Data 2000. So CIHS would not qualify in and of itself to offer those trainings. It would have to be sponsored through one of the groups named in Data 2000, those trainings.
Yeah, we should be able, I mean, we estimate that there are, according to Bob Lubrin, 1,250 FQHCs and 8,000 sites nationwide. So that is something that we could work with in terms of HRSA. The other thing we need to keep in mind, the issue is stigma. And that is, as a physician, at least in the state of California, state of Massachusetts, Maryland, and Michigan, those are the states I have license, and I have to do CMEs. It's mandatory. Now, I can do Medscape free CMEs. I can go to pay $100 at CPDD for 20 hours of CMEs, but I'm paying for some CMEs anyway. So the issue isn't, because most of these courses are low cost. The issue is, do I want to be bothered with the patients? Therefore, the cost becomes a barrier if I don't want to be bothered with the patients. So we also have to figure out how to deal with the attitudes about the patients, because suddenly practitioners view the cost as prohibitive when they have no problem schlepping off to resorts, doing CMEs, half-day courses, the other half on the golf course, or bringing their family, paying. It costs a lot of money to take your whole family to some of these events, and they do that routinely. So, but if I don't like the patients, $200 for 8 hours of training is suddenly a barrier.
I think we all probably would agree with that. That the stigma problem exists. Now, the strategy that I want to suggest, particularly to you, Mr. Botticelli, is the following. I address it to everybody, but I need your full attention because I don't want to do anything that's going to create a problem for you.
I might do something like for you.
That's, hey, you're on your own. What I am thinking about, and I haven't even talked to Senator Hatch, but it strikes me here that if there's obviously a consensus here on most of this. There's different, how much of the limit should be increased. Should we increase the limit? What kind of caution? How much caution? That's fine. But for the most part, there's agreement that we need more access to this kind of care. And we need more physicians willing to provide this kind of care. And one of the, whether that involves medical school, involves licensed physicians, a lot of other things. One of the great ways to do this in this country, to address a problem like this, is the White House, particularly the First Lady in this case, who is the logical one in my mind, and I know her well because she was a Senate spouse here at one point. But even if I didn't know her well, I think she might be open to this. And I want you to think about this, because I don't want to do this if it is for reasons I can't think of at the moment, create a problem. But that if Senator Hatch and I wrote to the First Lady saying that you and all these others came together, that there's a problem here, we need additional people to prescribe, we need additional docs, we need a stigma. We got to address the stigma issue, which is the White House can do as well as anybody, by the way, because if they have a little forum, not perhaps as many people as this, but a few people, particularly if there's a few folks who are willing to talk about their own personal experience, but not necessarily, that can have a very powerful impact. If she's the right one, it could be the vice president, could be the president, obviously himself, but he's got other things on his plate at the moment, probably, which are a little more immediate. But as immediate as this is, probably Iraq has got greater immediacies. Anyway, putting that aside, if that kind of a presentation and forum were held, where, for instance, the First Lady calls on medical schools to add this on, calls on doctors' organizations, physician organizations to take this on, I think it could really have a powerful impact. Will you either give some thought to that possibility where we would write the First Lady, talk about the meeting that we had here, we could either describe who was here specifically. We wouldn't represent anybody. We would just say we had a forum where a lot of folks got together and agreed at least that these couple actions need to be taken. Whether we want to use the word epidemic or not, there's a problem. I mean, where I live, it's an epidemic, but we'll use the words which are not, which everybody can kind of accept.
The CDC is calling it an epidemic. They're saying it's the worst drug addiction epidemic in our
Whatever.
history.
Give a little thought to that, would you? I haven't even talked to Senator Hatch about this, but my hunch is he'd be open to it without binding him. A letter.
No, so I think that one of the things I want to mention to you, and I think to other folks in the room, is actually tomorrow at the White House, we're actually having a summit with many of these same people in the room here to discuss the opioid issue.
Right.
It's the discussion and the strategies are fuller than just access to medication-assisted treatment of buprenorphine, but clearly that's something that we want to talk about. So we'd be happy to have a conversation because clearly the administration has some interest in thinking through what are some additional actions we can take here.
Is the president or the vice president or the first lady going to be at that summit tomorrow?
No, it's actually tomorrow. The vice president's actually in Brazil for the World Soccer, but the Attorney General.
How long is he going to be there? He's had enough fun down there already.
The Attorney General is actually speaking tomorrow, as well as Governor Shumlin from Vermont, who many of you know gave his entire State of the State address around it. So, but I think we can have subsequent conversations.
Let us know about that idea. Okay. We'll talk to Senator Hatch and see if he'd be willing. I'm sure he would be, but I can't speak for him. Anybody want to add anything before we stop?
On the issue of contacting the First Lady, I'd like to point out that it wasn't until 1986 and 16,000 HIV/AIDS deaths that Ronald Reagan first uttered the word HIV/AIDS, and he was rightly criticized for that. We've had, over the past 10 years, more than 125,000 Americans die from painkiller overdose deaths, and we have yet to hear one word from President Obama about this issue. So I would strongly urge you to reach out to the First Lady and to the President and ask them to speak up about this issue.
Yeah, well, that's another reason to do it, is to fill in, but so far apparently has not been adequately, if that's accurate. I haven't read all the speeches, you probably have. Don't tell them I haven't read all the speeches. But anyway, that may be an added reason. They may feel that that's something they ought to do for, even if there weren't going to be a forum at the White House, that's something they ought to speak out on, and a forum may be a good way to do it. I mean, if that kind of focuses. I mean, I've been to a number of those things. For instance, we had the First Lady and I think the Vice President together did something for children of military families. I remember that one because my wife was involved in that one. But they do this occasionally, and they're very effective, and they're well covered. So thank you. Those of you who have written testimony,
If you could just make it available to us today, if you could just...
if you could get it to us or leave it with us. We're going to get this transcribed and get this into the hands of a lot of folks that we think will be impacted by it.
Can I just make one comment on the physician piece? You're talking about trying to engage more physicians. Is there a way to make it so that some of their CMEs have to be in addiction, much like we've done with risk management, and maybe that might entice some to get involved as they'd have more knowledge, not just talking about med students, but physicians that are already practicing?
I think that is something which ought to be, ought to be added to the list.
The Federation of State Medical Boards would probably be interested in that. I know California and Massachusetts and Michigan require pain courses and pain.
And risk management.
Right, so.
Yeah. By the way, I'd be interested in any states. I think, Dr. Clark, you mentioned that there's some, or maybe you mentioned some states are looking at restricting bupe. And if you could get us any information on that, I'd be interested in that. I'd like to, maybe Senator Hatch and I could write some of our colleagues from those states talking about some of the testimony and the other evidence that we have about this matter and give them a little bit of history. And I want to also, there's some people who oppose the greater access to bupe for reasons which are other than the ones that are obvious on the surface, and I'll leave it at that. I won't go beyond that because I don't know that it's true. But there's some competitors sometimes that have an impact. All right. That's off the record. That was off the record. Thank thank you all. This has been very, very helpful, and it will have an impact in many ways. Thank you. Thanks.